So, sir, it's 3, 2, 1. Over to you, sir. We are live audience, sir.
Uh, yeah, good morning. Again, this is the second Sunday of the month of June 2025, and we are here again with FOGSI ICOG PG Clinic. This time we are having very interesting topic, and I just remind you that this program is going on for last more than 3.5 years, and we are doing it every month, second Sunday of the month at 11:30 a.m. And we have revised our schedule. Nowadays, we start with the pelvis and skull demonstration, which is very important component of PG learning, where we have to understand the simulation of mechanisms of labor and about other things about the fetus and intrauterine processes. Then second part is the case discussion on a particular problem, and we try to simulate the case discussion as being held in our practical viva voce examination. So third part is we have introduced is the skill-based learning, where we want to enhance the skill of the student, and it is a simulation again where our teachers demonstrate how to do a thing, how to do. And in this, we try to see that student learns the procedure or any important step which is there in our PG curriculum. And in the end, now we also try to have a component which is a quiz for our postgraduates, a half an hour quiz. So this all completes our program for every second Sunday of the month. And at the outset, I am very grateful to our FOGSI president, Dr. Sunita Tendulwarkar, and our ICOG chairperson, Dr. Parag Biniwale, for giving us this opportunity and continuing their support for the program over a period of last 3 years or so. And we have our vice chair, Dr. Vice Chairman elect, Dr. Sheila Mane, and Dr. Secretary, Dr. Sarita Balao also, who are supporting this program continuously. And today, I am again grateful to our faculty for sparing their valuable time on the Sunday of the month. And Dr. Sarina, as usual, she's a very uh, fond of teaching, and students are also very fond of. And we were trying for a long time to, and we were keep doing the request that she should be on our platform and try to provide her uh, advice or whatever uh, tips and tricks are there with her to the students. Then we have our faculty, Dr. Poonam Goel, Dr. Jaya Chaudhary, and Dr. Biswas, and obviously Dr. Ashish. They are there for the case discussion. And this time, Safdarjung Hospital, New Delhi, has agreed to present the case, and Dr. Sumitra, the faculty, is the coordinator from Safdarjung Hospital, and students from Safdarjung Hospital will be presenting the case. And in the end, we have, as I told you, the skill how to do it, and we want to show the student, and we want them to learn about how to take pap smear or LBC or HPV test, because in other words, how to do cervical screening, practical tips. So Dr. Dipanvita Banerjee, a young onco surgeon, will be demonstrating how to do these tests, and we'll be waiting for her uh, uh, videos and her presentation. And in the end, we have a quiz on pregnancy with heart disease, and Dr. Archana Kumari, our chairperson of FOGSI Quiz Committee, will conduct the quiz for half an hour, and we'll see who is the winner today. So thank you all for joining the program today. And I am also thankful for Dr. Ashish Mukhopadhyay sir and Dr. Hafizur Rahman, who are continuously helping us in running this program. And without their support, I think it is not feasible and practical to run the program for so many years. So, without wasting much time, now I invite Dr. Ashish Kumar sir to welcome the participants and the faculty, and then Dr. Hafizur Rahman will conduct the program. And meanwhile, as and when we will have our chairperson or our other office bearers of ICOG, we will invite them to give their comments. Yes, sir.
Yes. Thank you, Dr. Ashok Kumar, and good morning to everyone, learned faculty members, the office bearers of FOGSI and ICOG. You just heard about our ICOG Vice Chair address to you. Yes, 3.5 years and still counting. It's a long time. Dr. Sarina Gilvaj was talking about this. And initially, or rather at the very outset, ICOG had a very modest beginning. We just started with a case presentation. All of you know that. And then gradually, as the NMC norms, unfolded, we added. Today, it is comprising of 4 sessions. The first one is, of course, the demonstration of the dummy doll, which is a very now an essential and obligatory part of the PG examination these days. The second part is constant, that is the case presentation. The third one is at the master the skills and master the techniques, in which we try to refresh. The students are continuously in the teaching process in medical colleges, just to refresh their knowledge, and some small tidbits we can add or contribute to them, which can efficiently help them in the examination. Just to add some spice and knowledge bit into the program, we have recently added a FOGSI quiz, which is a very integral part of interest generates knowledge acquiring for the students, and that is why the quiz. And since we have started quiz, we had a lot of debates about adding the quiz because it's extending the program by half an hour in the pre-lunch period. But we have found out that it is very useful for the students and they are liking it. We can see that the participations of the students. So with those, and we wish to continue, and we want to modify continuously. We want to update ourselves continuously in ICOG because we want to keep ahead of time, or at least at par with the NMC norms. So the students are helped very well particularly for the examination. Thank you very much. And as Dr. Ashok Kumar has said, we are grateful to the FOGSI office bearers and as well as the ICOG office bearers, and they have helped us tremendously, not only in continuing the program, but also giving them active support. Thank you very much, and let the ball rolling. Let the ball rolling start by Dr. Hafizur Rahman. Kindly introduce and invite Dr. Sarina Gilvaj. Please.
Thank you. Thank you so much, sir. Good morning to everyone. So as Ashok sir was saying, this is actually running the 4th year, almost going to complete 4th year. So we are having this program with the blessings of FOGSI President, ICOG Chairperson, as well as Dr. Ashok Kumar sir and Dr. Ashish Mukhopadhyay sir is always there. So without having much time, we will start our first session. That is, we have kept it constant over the years, over 1 year at least. That means it is session on master the dummy pelvis. So today we have with us a very experienced Madam Professor Dr. Sarina Gilvaj, Madam. Madam is professor at Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. So Madam will explore on mechanism of labor and principle of management of normal labor. So I'd like to invite Madam. Madam, you can start. It's you. And I'd like to request students to have focused on the session because this is very basic in the postgraduate examination. Over to you, Madam.
Thank you. Thank you. And the answer, good morning, everybody. Dr. Sunita, President, Dr. Parag Biniwala, my dear friend, Dr. Ashok Kumar, Dr. Ashish, Dr. Hafizur, and dear students. Today we'll be talking on some very basics, that is the skull and the pelvis, okay? Now you can see this, I think probably I might even stand up for you to see better. Okay, now today we are going to start with the pelvis. Now whenever we use the word pelvis, we mean this bony pelvis, okay? Whenever I say it's a pelvic structure, etc., and to be more correct, it will be in the true pelvis. So this pelvis is made up of 2 innominate bones, the sacrum and the coccyx. The nominate, as you know, is made of the ilium, the ischium, and the pubis. Okay. Now, it is attached to the sacrum by the sacroiliac joint. Okay, sacroiliac joint here. And this is a synovial joint. Okay. And this, the pubic symphysis here, this is actually a fibrocartilaginous joint. Now, you know that this falls, there is a false and a true pelvis. The false pelvis and the true pelvis is demarcated by the linea terminalis. Okay, linea terminalis. So this is the false pelvis, the part above that. If you ask me what is the place of the false pelvis, actually it has no role except that it holds the pregnant uterus. Okay, as it is growing, it holds the pregnant uterus. But we concentrate on the true pelvis. Now, the true pelvis has got a brim, a cavity, and an outlet. Now, when you talk about the brim, the widest part of the linea terminalis is the transverse diameter. And I'll tell you ways to remember what I'm telling you all also. Okay, remember this number 13. Okay, this is 13 centimeters. Then you got the oblique diameter at the brim, which is from the sacroiliac joint to the opposite iliopectineal eminence. And it depends upon whether it is right or left, whether it is starting from which sacroiliac joint. So this will be the right sacroiliac joint. So it's a right oblique. Okay. Then after that, you've also got the 3 anterior posterior diameters. Now, this is where the vagina would be. Okay. This vagina, when I put 2 fingers into the vagina, I go straight in, and what I touch is the sacral promontory. Normally, the sacral promontory cannot be touched. Okay, it cannot be tipped. Now, what is the sacral promontory? The sacral promontory is the anterior border of the first sacral vertebra. This prominent part is the sacral promontory. So I put my hands into the vagina and I try to touch the sacral promontory. As I told you, in a good pelvis, we cannot tip it. So I won't talk about that, but just to tell you that from this apex to the sacral promontory is a diagonal conjugate. Again, remember these numbers 10, 11, 12. So this would be 12. Okay. And then you got the real anterior posterior diameter. The real anterior posterior diameter is again from the sacral promontory to the upper part of the posterior surface of the pubic symphysis. This has got no value. This is the anatomical conjugate or the conjugate vira or the anterior posterior diameter. But what has really got value is the obstetric conjugate, which is the innermost border. It is from the sacral promontory to the innermost border on the posterior surface of the pubic symphysis, because that's available space for the baby to come in. So it is 10, 11, and 12. Okay, remember that. Now, when you come to another one more diameter, I'd like to tell you, and that is the sacrocortiloid. You being PGs, you'd be asked what the sacrocortiloid is. The sacrocortiloid starts from the middle of the sacral promontory to the ipsilateral iliopectineal eminence. Okay. This is again about 9.5 centimeters, and it is here in a flat pelvis the engagement occurs. The biparietal diameter in a flat pelvis enters through the sacrocortiloid. That is the significance of the sacrocortiloid. Okay. So I've told you everything about the brim. Now there is one other thing which I have not told you. It is called the posterior sagittal. The posterior sagittal is where the anterior posterior and the transverse meet. From that intersection, the posterior segment. That is, now remember the numbers 5, 6, 7. So at the brim, it is around 4.55 centimeters. In the cavity, it is about 6 centimeters. And at the outlet, it's about 7.57 centimeters. Okay. Now that is about the brim. Now coming to the one more thing which I have not told you about the brim is the inclination. See, in the normal anatomical position, like how you and I stand, the anterior superior iliac spine and the pubic symphysis will be on the same line. Okay, that's how we stand. So basically, there is a pelvic inclination. This is the angle of pelvic inclination, which the inlet diameter, this angle to the horizontal. See where it goes, my pencil, it goes down and you draw a horizontal line. That part is actually the pelvic inclination, which is about 60 degrees. Now, when there is a sacralization of the last lumbar vertebra. It becomes a high assimilation pelvis. So then what happens? The angle of inclination increases to more than 60. It is that which predisposes to occipito-posterior. Okay, right. So that is about the brim. Now, when you come to the cavity, when I use the word cavity, the point which tells me first is the ischial spines. That is the station. That is the landmark. That is the most important point in the. Whenever I say anything in relation to the ischial spines, that means I'm in the cavity. Okay. Now, when you take the least pelvic dimensions, you can remember the tips. The tip of the pubic arch, tip of the spines, and tip of the sacrum. So the tip, sacrum, okay? So the tip, all this forms the least pelvic dimension. That means that is the smallest diameter through which the fetus could pass. And if it can pass through that, then it can pass through the entire pelvis, okay? And then when you take, there's something called, to see whether there's a contraction at the level of the cavity, if you take the interischial spinous diameter, normally it's about 10.5. Don't say 10, because 10 would be the borderline for a contracted pelvis. So say 10.5. The sum of that and the posterior sagittal in the cavity should be more than 15.5 centimeters. If it is less than 13.5 centimeters, it tells you it's a contracted pelvis. Okay. So that is the most important part. And when you come to the subpubic arch, remember it's about 85 to 90 degrees. Don't forget that. So it should normally admit 3 fingers. Okay. That will be a good subpubic arch. When you come to the outlet actually, it's again, you will have a common factor, the subpubic arch, but it is to the tip of the coccyx. Okay. So basically, if you see the baby is a very smart baby. It enters through the largest diameter in the transverse diameter or in the oblique, because this is 13 and the oblique is 12.75. So that is why always we talk about an occipito transverse or an occipito anterior. Okay. But then it has got to manipulate its way in such a way that when it comes out, it has got to come out through the largest anterior posterior diameter, which is about 12.75, 13 centimeters. Okay. So the tip of the coccyx. The transverse diameter of the outlet is actually the intertuberous. This is where we sit on. So you take your hand out of the vagina and then you check the intertuberous, which admits the fist, which is 4 knuckles. So if you're asked which are the 2 diameters which you can measure in the pelvis, it is actually the diagonal conjugate, from which you can subtract 1.5 centimeters to get the obstetric conjugate, and the intertuberous. They are the 2 clinically measurable diameters in present day. Okay. Then I'll just tell you a few other things also before I wind up the pelvis. The depth of the pelvis. The depth of the pelvis, you all know, is 10 centimeters. So the spine is zero station. It is -1, -2, -3, -4, -5, +1, +2, +3, +4, +5. So now it has become very easy for us to know that this is the depth of the pelvis, and mainly in the posterior part of the pelvis. Then there are another 2 other terms which you should know. One is what is that? The caput molding and things like that. I will tell you that when I tell you about the fetal skull. But there is something else which is called the axis of the pelvis. Okay, axis of the pelvis is actually an imaginary line passing through the axis of the brim, the cavity, and the outlet. And you know what this axis is called? This is called the curve of Caris. The curve of Caris is a circular shape. It actually blends into the curvature of the sacrum. So that is the curve of Caris, which is nothing but the plane which passes, an imaginary line which passes through the axis of the brim, cavity, and outlet. But again, that hasn't got so much of significance as the obstetric axis. The obstetric axis, on the contrary, is not a curved line. The fetus passes from above downwards, like downwards and backwards. At the level of spine, it turns downwards and forwards. You should know this. This is the obstetric axis. Okay. With the obstetric axis is passes downwards and backwards first, At the level of ischial spines, it comes downwards and forwards. This is important for you to remember when you do an instrumental tailwind. Okay. So with this, I will stop with the pelvis, and I'll tell you a few things about the fetal skull. Now look at the way I'm holding the fetal skull. See, this is a good way to hold it. You put your middle finger inside the foramen magnum. You saw the face, let your face rest on the palm. So whenever you talk about the pelvis, see, this is the occiput and this is the spine. This is the spine. You understand? So the spine, you can show the mechanism so easily. Now quickly telling about what the fetal skull has got. The fetal skull, this skull has got a vault, a face, and a base. We won't talk about the base, the bones are all fixed. You got the face, we won't talk about it, but we'll talk about the vault. So whenever now see when you say a baby is anencephalic, no vault, this is what you mean. There is no vault here. So the vault comprises of, you all know, it comprises of the occiput, the two parietal bones, and the two frontal bones. We won't talk about the others. We won't talk about the temporal, etc. Now, they are all bound to each other by membranous connections, and this is called the suture lines, okay? But there are two fontanelles of significance for us. Where the suture lines meet, that is a fontanelle, okay? Where the suture lines meet, you got an anterior fontanelle, which is a diamond-shaped or rhomboid-shaped structure there, which is in the junction of the metopic suture line, the coronal. See, this is called the coronal, like how you place the crown, you place the crown like this, so that's called the coronal suture line. And between the two fontanelles, that is anterior fontanelle and the posterior fontanelle, you've got the sagittal suture, okay? The sagittal suture basically is between the two parietal bones. Now, and beyond that, between the occiput and the parietal, you've got the lambdoid sutures. Now, it's very important for you, if you're asked, what is the vertex? In a well-flexed head, the vertex is the most dependent part. And the dependent part, this vertex is between the two fontanelles and the two parietal eminences. See, this part is called the vertex, okay? Now, coming to tell you about the various structures the diameters which you come across in various mechanisms. I will just mention, we normally talk, remember the sub, don't you forget the word sub. So in a vertex presentation, when I say vertex, that means the head is well flexed, okay? I have proved beyond doubt that the head is flexed, and that's why the vertex is presenting. So in a vertex presentation, it is the sub-occiputobregmatic. Sub-occiputobregmatic, okay? Don't forget the word sub. It is below the occipital protuberance to the middle of the bregma. And when you say in a face presentation, again another sub. There is no face without the mentum. Without the mentum, you cannot use the word face. So submento, remember the word sub, it is between this and the neck midway here. So submento, again bregmatic 9.5, and the two biparietal diameter, again another, which is the largest transverse diameter. That's why we say engagement occurs when the largest transverse diameter has entered through the pelvic brim. Okay, so that is the biparietal diameter. Now, in a brow presentation, okay, in a brow, it's called verticomental. As the bird flies across, this is the mentum. There is no sub in this. It is the mentum to the highest point of the vertex. As a bird flies across, it is 13.5. There is no diameter in the pelvis as big as that. And so in a brow presentation, you must always do a cesarean, whether the baby is alive or not. Okay. So that is about the brow. Now, so I've told you about, then another thing which you must remember, the deflection. Deflection which you get in occipito-posterior, you got the occipito-frontal. See, the head is deflexed. Both the fontanelles are on the same line, and you find the head is deflexed. It is occipito-frontal. It must be more than 9.5, right? So you can say 10.5, 11 centimeters. Okay, that is the occipito-frontal. Now, I want to tell you some other things, okay? Now, let us imagine that I'm talking about the commonest mechanism, which is the left occipito-anterior. Whenever I do a PV, I feel 2-3 things which will tell me a lot of things, okay? When I feel the sagittal suture, it will tell me the degree of internal rotation. Remember that. See, in a normal occipito-anterior, if it is here, that means it's not fully rotated. When it is coming like this, it's fully rotated. So sagittal suture will tell me about internal rotation. The posterior fontanelle will tell you about the position of the baby. If the posterior fontanelle is in the left anterior quadrant, it's the left occipito-anterior. Okay. So the fontanelle, will, if it is in the right quadrant, and remember my pelvis. So if it is on the right side, that means it's a right occipito anterior. So the posterior fontanelle will tell you about the position of the baby. And in an occipito posterior, okay, now look how I've turned the pelvis. In an occipito posterior, what you feel is the anterior fontanelle. The anterior fontanelle is normally felt in the anterior quadrant, okay? You feel it there. So the anterior fontanelle will always tell you about the degree of flexion. So I've told you 3 important landmarks and things which you must remember when you do a PV. The sagittal suture will tell you about the rotation, the anterior fontanelle will tell you about the degree of flexion, and the posterior fontanelle will tell you about the position of the baby. Then I'll just tell you what two or three more things. There's something called a physiological molding. A physiological molding is when both the bones, there is always a gap of 4 millimeters. Remember, 4 millimeters. And you know, 1 plus is just touching, or 2 plus is overlap reducible, and 3 plus is when there is irreducible overlap. And please remember, there is this overlap occurs. We are bothered about what occurs at the level of the between the occiput and the parietal and the parietal. So parietal is one area which we should look at. That is the sagittal suture. We look at the molding, and occipito-parietal. So these are the 3 sutures we normally count for when we talk about molding. Okay, 1 plus 2 plus 3 plus. And let me tell you one thing: the parietal bone reigns supreme. So in other words, even the occipital bone goes under the parietal bone. And the posterior parietal bone, if there is a posterior parietal bone, that goes under the anterior parietal bone. That is how molding happens. And so one bone goes over under the other bone. But who's supreme? Parietal. Parietal is right on top. Okay. Then just to tell you about the caput. Now you all know it's the most dependent part. But looking at the caput, you will also know the position of the baby. For example, now this is a left occipito anterior, right? In a left occipito anterior, you will actually find the caput over the right parietal bone. Do you understand? And in a right occipito anterior, you will find the caput over the left parietal bone. Please remember that. So looking at the caput also, you can probably say the position of the baby. Okay, and so in a left occipito anterior, the caput is over the right parietal bone, and in a right occipito, it will be on the opposite side, left parietal bone. That's another thing. Now, so I've told you about what is something about the clinical significance of molding, caput, etc. Now, I think I'll go to my case presentation. Yeah, I wanted to tell you one more thing, very important. Okay, see, that is synclinism. Synclinism, I told you the baby always enters in the transverse diameter because it's the largest diameter, transverse or oblique. Now, when it enters, always the descent is synclinism. That means the sagittal suture is always midway between the pubic symphysis and the sacral promontory. Midway, okay, midway. This is synclinism. Now, supposing it tilts. Now, look at this. It has tilted towards the pubic symphysis. So, the posterior parietal bone is presenting. When the posterior parietal bone presents, this is called the posterior asynclinism. In other words, whichever parietal bone presents, that is the asynclinism. Do you understand? So this is the posterior asynclinism. And when it tilts like this, when the sagittal suture tilts towards the sacral promontory, the anterior parietal bone presents, and that is called anterior asynclinism. And I will just tell you one more thing. The anterior is good. It occurs in multis. The posterior is bad. You know why the posterior is bad? You should know. They will often ask you the exams, which is a better asynclinism and which is bad. I'll tell you why the posterior is bad. Now, when it is in a posterior asynclinism, the sagittal suture is closer towards the pubic symphysis, and it is presenting as this. Then what happens is, to become synclinism, this parietal bone, anterior parietal bone, must go through the entire posterior surface of the pubic symphysis to become synclinism. So it's a long journey. You understand? That is why the posterior asynclinism is bad. Now, in an anterior asynclinism, you will understand that this posterior parietal bone need bypass only one point, and that is the sacral promontory. So that is why when you take the 2 synclinisms, the posterior is bad, PB is bad, okay, it's bad. In other words, because it has got to go through a larger diameter. Can I have the next, can I have my case presentation? Can I share my
Yes, ma'am.
presentation?
Yeah, ma'am.
Can I?
Yes, ma'am, please.
Can you see me? Can you see my presentation?
Yes, ma'am.
Can you see it?
Yes, ma'am. Ma'am, can you make it slideshow?
But I don't see it.
There is a button in the right or you can press the
Yeah,
F5.
Is it okay
Yeah.
now? Right. So
please.
friends, now that I've told you so much, you've got an idea, right? And I'll tell you something more. You'd be often asked mechanism of labor in the exams. So how you should start. This is how you should start. Mechanism of labor is actually defined as the manner in which the fetus adjusts. You just remember this word adjusts itself to pass through this parturient canal. You know, the bony canal, it has got to pass through that and then with minimal difficulty. And there are some cardinal movements, okay, of the head to negotiate to facilitate good delivery. Now, whenever you are asked any mechanism, this is how you should always have an intro. Now, for example, I'm asked in the exams, okay, now what is the, tell me, doctor, the presentation left occiput to anterior. So immediately I'll say, this is a longitudinal lie. It's a cephalic presentation. So I said cephalic. I did not say vertex. When I say cephalic, it can be deflex, not flex, etc., etc. But when I use the word vertex, that means the head is flexed. Okay. So the attitude is one of flexion. The presenting part is the vertex, and the back is felt on the back. See, I'm going to talk about. See, the back is felt on the left side. The limbs are on the right side. Now, there is something called a cephalic prominence. You're often asked, what is a cephalic prominence? The cephalic prominence is what you normally come across, as the first prominence as you come from above down, and it can be made out in the second pelvic grip. Remember that, okay? So the cephalic prominence in a vertex presentation is the sinciput. See, it is the sinciput. And because the occiput is down, you know the sinciput and there's the occiput. It is well flexed, so the occiput is down. So I will say that the cephalic prominence is the sinciput, madam, and it is on the opposite side of the back. Do you understand? That means I am telling them that it's a well flexed head, the sinciput is up, the occiput is down. That is cephalic. For example, I'll tell you one more thing. Now, supposing it's a completely extended thing. So in a face presentation, the cephalic prominence is the occiput and it is on the same side as the back. It is on the same side as the back. It is the occiput. Have all of you understood? But in a vertex presentation, it is the sinciput and it is on the opposite side of the back. You must say in relation to the back. But in an occipito-posterior, there is no cephalic prominence because the sinciput and occiput are in the same line, the military attitude of the baby. Okay, right. So the fetal heart will be heard in the left lower quadrant. I won't talk about all that. PV, you know all about the sagittal suture. Normally in an anterior position, you feel the sagittal suture and the posterior fontanelle. Now you all know engagement, descent. So I'll just tell you, you should hold the baby like this, I said. Now I'm going to talk about left occiput to anterior. When I talk about that, I must stand up and say, I've already given the intro, longitudinal like cephalic presentation, vertex presentation, denominator occiput, 9.5 centimeters, everything I've given the intro. Now engagement occurs, descent with increasing flexion. Then when it touches the pelvic floor, it undergoes internal rotation. Then after that extension, baby's head is born by extension. And then I want you to know restitution means going back to the same. So wherever the occiput started from, you turn it like that. That is restitution, untwisting of the neck, and external rotation. E comes last. You're always happy at the end, and so you say E and you smile. And so that's when you say E as the last. So external rotation comes last, which corresponds to the internal rotation of the shoulders. Okay. Now, I told you about asynclinetism. The biparietal diameter, when it is an occipital transverse, there is synclinetism. But asynclinetism in a flat pelvis, I told you that is where the superior subparietal, and that is 8.75. I've told you about anterior asynclinetism, which is good, which occurs in multis. The posterior, which is a Litzmann's obliquity, or the posterior asynclinetism occurs, it's bad. It occurs most often in the primaries. it can be, the descent can be assessed by the second pelvic breath. Why does descent of the baby occur? Because of the pressure of the fundus on the breech. The fundus of the baby, the fundus of the uterus presses on the breech, and that's how descent occurs. And the hydrostatic pressure. And during descent, actually, the baby straightens a little. Okay, plus the abdominal muscle contraction. The flexion brings the head into contact with the chest. You all know that we're always bothered about the head comes in contact with the chest due to the resistance from the pelvic floor, and the suboccipitobregmatic diameter 9.5, you know that also. The internal rotation, as I told you, it occurs. They often ask, why does internal rotation occur? It is due to the elastic recoil of the levator ani because of the shape of the pelvis, the gutter-like effect of the levator ani, because of the well-flexed head and the effective uterine contractions, and most important, impetus given by the ischial spines. Now, because the results of the two forces are there is a downward pressure from above, okay? And because of all this, the head has turned like this. Now it is going to extend. Now, before it extends, it crowns. Now, that is its crowning glory. Do you understand? So, in the crowning glory, what happens? The biparietal diameter is caught. The biparietal diameter is caught there, the vulval outlet. And then what do you mean by crowning? That this biparietal diameter is stretching the vulval outlet. It does not recede in between contractions. And delivery occurs by extension. But let me tell you one thing about delivery. That you should not allow the head to flex until the biparietal diameter and the occiput. So basically, first you're pushing the head down to promote flexion, so that by a controlled extension, it will come out. So the biparietal diameter and the occiput should come out before you. Then restitution, I told you, untwisting 45 degrees and external rotation, we're all happy in the end, and it's another 45 degrees and internal rotation of the shoulders. Delivery of the shoulders, the bisacromial diameter. Now, if you pull before this complete external rotation has occurred, the shoulders would not have rotated and you will land up with shoulder dystocia. So wait for the head to go external restitution, external rotation. By then, the shoulders have come to internal rotation. Then the anterior shoulder is born, and then the posterior shoulder is born. By lateral flexion, the rest of the body is born. Lightening. I want you to remember LL. Lightening is because of the formation of the lower uterine segment, and it presents as the presenting part descends into the pelvis in late pregnancy. You understand? When it descends into the pelvis, because the lower segment is not normally, it's a isthmus, right? It forms only in the last trimester. So it's that more so in the last month. And when it forms, then what happens? The presenting part comes down. So there's a falling forward of the uterus. At that time, you've got a shelving sign. If they ask you to demonstrate a shelving sign, you say, I'll bring the patient to the edge of the table, allow her legs to hang down from the chair. And then if I keep a book on the fundus of the uterus, it will remain. That is a shelving sign due to lightening. Okay. Now, ripening, if you ask me, if you're asked in a simple word, what is lightening? Just say this. It is a soft, short, stretchable cervix. SSS. It is soft. You got it. Short, that means it has become effaced. Stretchable, that means it is dilated. You understand? So whenever we do a pre-induction cervical ripening, it is to make it SSS, soft, short, stretchable. Now, you might be asked, what is false labor? False labor pains is, it normally occurs at term. Remember that. It is before the onset of the true labor pains. It's irregular contractions. It is not associated with cervical changes, and there is slight pain in the lower abdomen. It may be due to a loaded rectum. It is relieved by analgesics and laxatives. Okay. Now, stages of labor, you know there is a latent phase and an active phase. And today, the active phase begins at 5 centimeters. That is, all of you must remember. It is a WHO's 5. We all would remember that. That is the active phase of first stage. Full dilatation to delivery of the baby is called the second stage, and they've got a pelvic phase and a perineal phase, or it's called a passive phase and an active phase. Third stage is separation, expulsion of the placenta and membranes and control of hemorrhage. And fourth stage is the most important stage, postpartum monitoring. Don't shift the patient out of the labor room without doing your 2 hours of monitoring. Okay. I'll just tell you a little more about the second stage, okay? The second stage I told you is the pelvic phase because it comes down, Amma. It comes down a little more in the pelvic phase. It has not, you know what the pelvis I told you is a bony pelvis, right? So it has come down, but it has not touched. The perineum is where you give the episiotomy, okay? So it has not come to the perineum. So it is still in the pelvis. So there's a pelvic phase and a perineal phase. And today the ACOG, everybody accepts that in a normal primate, it is 3 hours. We must give more time For second stage, in order not to intervene unnecessarily, and for multis, it is 2 hours. So remember 2/3. And then if with the epidural, it becomes 4 hours and 3 hours. This is accepted world over. So this is what I was telling you when you're delivering the baby. See, you got one your non-dominant, your dominant hand is giving the perineal. Even if you give an episiotomy, you must give pelvic support, perineal support, sorry. So you will have to, first you will have to actually give in order to prevent a sudden extension, you're actually promoting flexion. And I told you 2 structures should come out, the biparietal diameter and the occiput should come out. Once that has come out, then you allow the head to extend and come out, okay? Then restitution and so on. And look at the perineal support. I won't talk much about it. So you all know what is crowning. I told you it's a biparietal diameter held at the vulval outlet, and it does not recede in between contractions. And at that time, what you're doing is you're giving perineal support, no? You're actually easing out the chin out. In fact, you're promoting extension at that time. So that is called the modified Ritgens. So you saw that once the occiput and the parietal eminences are free, then by a process of extension, the forehead, nose, mouth, and last to deliver is the chin. So the suboccipitobregmatic diameter comes out instead of the occipitofrontal. If you don't allow it to flex a little bit, you'll get the occipitofrontal, then it will tear and come out. So allow it to undergo little flexion till the parietal eminences and the occiput are out. Then you allow it to, and everything is slow. Remember the word slow, labor, SLOW, okay? Now the structures that are cut, you know why I'm running through, because I've got just a little more time and I want to tell you all a lot of things. Okay, now the structures which you cut in an episiotomy. You cut the skin, the mucosa, that you remember, the vaginal mucosa, okay? Then that is the posterior vaginal wall, that is, we call it the mucosa. Then there is a superficial transverse perineal muscle, and beneath that is a deep transverse. The deep transverse is not always there. Sometimes it's absent. So the superficial and the deep transverse perineal muscles. Then you saw around that vulva there. I don't have a pointer and I don't want to touch it. My screen will go. So you've got that vulva there, around that is the bulbospongiosis. So you will start your episiotomy right plumb in the midline, and it will go down at 60 degrees. 60 degrees, you'll put the episiotomy. So you're cutting the superficial, you're cutting the vaginal mucosa, you're cutting the skin, 2 things. Then you're cutting the superficial and the deep transverse perineal muscles, the bulbospongiosis, right? And sometimes if it is a very deep episiotomy, you'll be cutting a part of the levator ani, okay? It could be the pubococcygeus part of the levator ani and the fascia covering it. Then you're cutting also the transverse, the pudendal vessels, the perineal branches of the pudendal vessels and nerves, etc. So this much you must know. And always remember, whenever you give the episiotomy, give it from the midline at an angle of 60 degrees. Midline is, don't start from this end, then you'll cut the labia, okay? Now look at, this is the new scissors in 2024. The AGOG showed us this scissors called the epi scissors. The episiotomy mediolateral is performed at an angle of 60 degrees on the midline at the crowning of the fetal head, resulting in a post-delivery angle of 45 degrees. I want you all to remember this now and always. When you're putting it on a stretched perineum, it is 60 degrees, and after delivery, it becomes 45 degrees. When you're suturing, it is 45 degrees. So because when you do this, you're preventing OAC. I won't talk about it but this scissors, you look at that, it has got one marker, a guide, which will tell you which is the midline. Otherwise, if you keep the scissors, you might even become a 90 degrees. So when that marker is there to show the midline and the 60 degrees. Okay, I'll just tell you a few words about water birthing. Many people are talking, you should not promote it, but I'm just telling you the principles behind water birthing, okay? See, water birth is a process of giving birth in a tub of water. You saw that her head is outside, but her body is inside, okay? And giving birth in a tub of warm water, it should be about 92.5 degrees centigrade. Water should be slightly warm. 0.0 degrees Fahrenheit, sorry. Some choose to labor in the water. You can have the first, second stage and all that in water, and they come out of the water to deliver. But some others deliver in the water itself. Therefore, the theory being, since the baby is the amniotic fluid, see, all its 9 months, it's in the amniotic fluid, right? And birthing is in a similar environment, is gentle on the baby. So even if the baby comes out, it will not aspirate. When does it aspirate? When it faces atmospheric air. So the baby will not aspirate. Only when you take it out of the water only, then only you cut the cord. And when you cut the cord, until then the baby is getting oxygen. Okay, so just to tell you that, nothing more. Many people are talking. So water birth should always occur under the close supervision of a care provider. Effect of buoyancy lessens the mother's weight, and water makes the perineum more elastic and very lesser tears. You don't get much tears here. Though RCOG has said there's a risk of water embolism, and the BMG has also said there's a risk of water aspiration. So nothing happens to the mom, okay? The mother's head is outside. Babies do not normally inhale unless they are exposed to air. They continue to get oxygen through the umbilical cord until the cord is cut, and the temperature being around 97 degrees Fahrenheit. Now, these are the guidelines which the RCOG has said. Antenatal information to the mother, the episiotomy 60 degrees. Even after episiotomy, you must give a perineal support. And after that, to do a PR, they say to do a PR, you might miss a buttonhole tear of the rectum. Just tell you 2-3 words about chorioamnionitis, which can occur in labor. Chorioamnionitis is characterized by infection, inflammation of the chorion and the amnion. Remember, there is the amnion and the chorion, they are fused. So whenever infection of the membranes occurs, it's called chorioamnionitis. And it often occurs when there is a premature rupture. Don't unnecessarily rupture the membranes, okay? When you rupture the membranes, an infection can ascend up, and then it can cause chorioamnionitis. So we normally don't give antibiotics in a patient in labor. We don't give, and there's an episiotomy, okay? But we give when there is a premature rupture of membranes for more than, pre-labor rupture of membranes for more than 18 hours. That's when we give antibiotics. Otherwise, in our hospital, we don't give it also. The new terminology, so from that infection, it can go to the amniotic fluid. Then later they tell you, madam, that patient you delivered postpartum has developed sepsis. That's again because of chorioamnionitis, the umbilical cord, the membranes, etc. So in 2015, the National Institute of Child and Human Development said that chorioamnionitis, they give another name. That's why I wanted to tell you all about this. It's called III. It's intrauterine infection or inflammation, or both. Okay, so III. Intrauterine is the first I, infection is the second I, and inflammation. Now, you all know there are 5 things you should remember in chorioamnionitis. There's fever, there's leukocytosis, maternal and fetal tachycardia, uterine tenderness, and purulent or malodorous amniotic fluid. Why you should remember it? The commonest organisms for this group is Streptococcus and E. coli. They are the 2 commonest infections can occur in chorioamnionitis. And when it occurs, your antibiotics should be given. And what antibiotics will you give? And this normally happens because you have done an early rupture and there's a prolonged labor after the rupture membranes, multiple. Don't do too many PVs. If you think you're going to get information from a PV, do it. Otherwise, 4th hourly PV is more than enough. Okay, so this is what the NICHD has said. We give, in our labor room, we give ampicillin 2 grams 6th hourly. Or if you're giving 1 gram, give it 4th hourly. Remember that. So we give 2 grams 6th hourly. In the presence of chorioamnionitis, you must give gentamicin 5 milligrams per kilogram IV only once a day, and metronidazole 500 milligrams 3 times. So clindamycin, it's an alternative for anaerobic coverage every 8th hourly. So we give a triple drug when there is a chorioamnionitis. And in our hospital, we also add, according to the new guidelines, we give a single dose of azithromycin. You can give it oral or parenteral, it doesn't matter. We give 500. If the patient's little obese, we give in 1 gram. So over and above this, we give that. You know why? Because it's a broad spectrum coverage that covers the urea, plasma, urelyticum. So this is a good combination to carry home for your hospitals. So the duration is another very important thing. Duration, ACOG has definitely said that in a III, you need give it only as long as she's in labor. You don't have to continue it postoperatively, postnatally, unless she's got temperature, etc. That means she's got infection of the uterus also, endometritis and so on. Then you got to give antibiotics. Otherwise, if it is just a plain and simple chorioamnionitis, once the baby and the membranes have come out, you can stop. That is, they have said you can stop. They said no additional antibiotics are required after vaginal birth. Then we all know second stage cesarean, the commonest causes fetal distress along with a non-descent when there's a CPD or a malrotated head. These are the 2 commonest causes. Along with fetal distress when we do a second stage cesarean section, okay? When there's a deep transverse arrest, etc. And how do we reduce? We reduce the second stage cesarean by the presence of a companion, proper hydration, allowing longer time for diagnosis. We'll be giving a longer time. I told you 2 and 3 hours for normal labor, 3 and 4 hours with epidural. And honing the skills of instrumental delivery. There is no time to talk about it, so I won't tell that. So the RCOG has said that operative vaginal delivery should be abandoned. I just want you all to remember one thing. If at any time during process of labor you're applying an instrumentation, The word progress, if there is no progress, please abandon the instrument and go for a C-section. Now, you all know in the third stage of labor, I think I've got another 5 minutes more. In the third stage of labor, we all give oxytocin. We give 10 units. It's what WHO has recommended intramuscularly at the delivery of anterior shoulders or at the time within 1 minute of delivery of the baby. But I'll just tell you about a few words about carbitocin, where oxytocin should always be refrigerated, always be refrigerated. So you got the alternative, which is a heat stable carbitocin. You can give that for the third stage of labor. You all know in the third stage of labor, we give oxytocin. Either you can give oxytocin intramuscularly 10 units thing, but in our, according to Kerala Federation, we give IV also. And then if you're giving carbitocin, only 1 dose of carbitocin, I just wanted you all to know, if you give, it is the ampule is 100 microgram of carbitocin, okay? If you give it intramuscularly, its action lasts for 2 hours. If you give it intravenously, its action lasts only for 60 minutes. But look at the onset of action within 2 minutes. 1 to 2 minutes, carbitocin's action is started. So within 1 to 2 minutes onset of action, its half-life, they say, is 40 minutes. If you give it intramuscularly, its action lasts for 120 minutes. If you give it intravenously, only for 60 minutes. Okay. And they have said there are many trials have been done. There is no time to tell you all about it, but you can take these slides. It's all yours. So the most important thing, you cannot give it for induction of labor. Please, only for management of third AMTSL. Only for that. What do we do for AMTSL? Active management, we give oxytocin, we give controlled cord traction. By the brand Andrew technique, we deliver them. We do a delayed cord clamping. The delayed cord clamping is more for the baby. Okay. And we don't massage the uterus now, but we can keep your hand there to check the tone of the uterus. That's what they say now. And remember, the carbitocin should not be given for induction of labor. It should not be given in the presence of renal, hepatic, and cardiovascular and epilepsy and hypersensitivity to the drug. Carbitocin comes as 100 micrograms in 1 ml, can be given IV. I told you IV is 60 minutes, IM is 120 minutes. And best given after delivery of the infant and preferably before delivery of the placenta. And this is a champion trial. I just wanted you all to know this trial, because they compared carbitocin to oxytocin. How good is carbitocin? You know how much they used? 100 micrograms of IM carbitocin versus 10 units of IM oxytocin. I just wanted you to know this. That was how they compared it, and they said it is a non-inferior to oxytocin. That was the result of the champion trial. And remember, if a baby is born asphyxiated, there's something called a cooling therapy. This cooling therapy should be given at a temperature of 33.5 degrees only for term babies, and it should be started within 6 hours of birth. Supposing you've got an asphyxiated child at birth, remember you should start it within 6 hours of birth. Okay, and it should be given for 3 days. So what does it do? It slows down the metabolic process and it decreases inflammatory cascade and thus minimizes brain injury and improves neurological outcome for the baby. So if your baby is born asphyxiated, it hasn't got a good Apgar and beyond 36 weeks, then you can prevent HIE by giving a cooling therapy. Okay. Another thing which you all should know as PGs is, we collect today, we don't believe in scalp blood pH is no more accepted, but cord blood, after the baby is born, we check the cord blood pH. We check the pH of both the umbilical artery and the vein. This gives a better reflection of the baby's oxygenation status and the overall metabolic status. It is blood is collected in, you put 2 clamps between 10 centimeters cord. It is collected in a heparinized syringe and immediately sealed, and it is sent, and you will get the pH, the partial pressure of oxygen, the partial pressure of carbon dioxide, and the bicarb. Okay, it will give a clear picture about, this is important even for medical legal cases. Remember this is a pH of the newborn cord. It is 7.2 to 7.3. If it is below 7, bad. Remember that. Okay, remember it's very bad. So when you don't do the pH, cord blood pH for every baby, but if your child is born asphyxiated, then you must do, for medical legal purposes, you must do a I wanted to tell you all one more thing about monitoring. You all know this was the first partogram. You all remember there was a latent phase and an active phase. Then came the composite, which had all the components. There's no time for me to tell you about that. I've got just 2 more minutes left. I just wanted to tell you that this was a composite partogram. Even this we have overcome. Then it became the modified, the composite partogram became the modified WHO's partogram, in which there's no more latent phase. It started straight off from 4 centimeters. But today, after the Zhang's and colleague, the Consortium of Safe Labor, we have started that Safe Labor Care Guide. And that gives you labor care guide, is otherwise called the next gen partograph. It was introduced in 2018. The labor care guide improves childbirth experience. It's respectful maternity care. You respect her privacy, her confidence, her confidentiality, and her dignity. Okay. So you must take care of all that. And you start plotting the labor care guide only from 5 centimeters. You all can take this with you. It's all yours. It starts from 5 centimeters. And they have said that the labor care guide, they have said that from 5 centimeters to the full dilatation, it is never more than 12 hours in a primary. It's never more than 10 hours in a multi. Okay. All the components are there. Where we had in the graph, we had the alert line. In the labor care guide, we don't have an alert line, but we've got alert. So you can go through all the alerts, and that's all yours. I would have loved to tell you all this, but there is no time. There are 7 sections. This is the first, second, third, fourth, and fifth, and sixth. And then it's a 7th is a shared decision. It's a shared decision with the patient and the bystander. That is, you always got a companion in labor for respectful maternity care. And that has come to stay. These are the differences. It's all yours. You can take it. And as indicated by its name, the labor care guide is much more than a technical monitor of labor progress and a well-being. It also prompts a comprehensive recording of all the important vitals. So in summary, the LCG gives respectful maternity care, effective communication, companionship, and a continuity of care. So friends, thank you. I just wanted to invite you all for our focus program. This is between August 25th and 29th. You need to remember only the last line, which is www.pgp, that is PG Program Focus, pgprogfocus.com. You can enter that and you can see the entire program. It's end of August. We close the registration after a particular number. The website is pgprogfocus.com. Thank you.
Thank you so much, ma'am.
Thank you. Thank you.
Thank you so much, ma'am, for your excellent demonstration, as well as how to take care of a normal labor and all the nitty-gritties in the labor management. And I'm sure this is going to give lots of learning abilities for the postgraduate students. And I'd like to tell all the students this will be in record also in future. Thank you so much, ma'am, for it.
Thank you. Thank you.
Yes, Dr. Sarina, you were very, very exhaustive in your lecture. I wonder how much the students can retain out of this. Of course, each and every point is important, but their attention span is limited. That's what I am very afraid of. So I think that we will discuss more about. There are certain points which we could have discussed about this presentation on normal labor and the things following, but today there is no time. Maybe some other time we'll discuss about those. Okay. So we'll be in constant touch with you, madam, about these things, and if necessary, we can.
Thank you all. Thank you
very much.
so much.
Thank you, ma'am. We'd like to have you in future programs as well. Please visit. Thank you.
Thank you. Thank
In
you.
the meantime, we have a pleasant job of introducing not introducing, actually, he is a very much part of the program. Our ICOG chairman, Professor Parag Biniwale, is here. Let us all welcome him with a round of applause. He has taken out time for joining here. And we would like to hear 2 or 3 lines of words of wisdom from him. Dr. Parag Biniwale, sir, Chairman ICOG. Yes.
Thank you, Professor Ashish Mukhopadhyay. Good afternoon, all. I bring greetings from ICOG, and it's indeed a pleasure to join this program from Bangalore, the presidential conference which I am attending. Thank you, Dr. Sarina Gilwas, for a wonderful presentation, and it was something which all the postgraduates, not only the postgraduate students, but even all clinicians should know as far as normal labor is concerned. And I'm certainly looking forward to the case discussion from the students of VMCC and Safdarjung Hospital, and they will be examined by our own Dr. Ashish Mukhopadhyay, Dr. Jaya Chaudhary, Dr. Subhash Biswas, and Dr. Poonam Goel, who's our governing council member, which will be followed by an interesting session on cervical cancer screening by Dipanvita Banerjee. And of course, thank you, Archana and the team, for conducting quiz with every program of PG clinics. I'm not going to interfere the sessions, let the flow go on, but then I didn't want to miss an opportunity to join the program. So happy learning to everyone. Thank you, Ashok. Thank you, Hafizur, and of course, Ashish, for your continuous effort for last 3.5 years. Thank you very much.
Thank you.
That is Parag, and our chairperson of ICOG, and he's always keenly interested in joining this. Wherever he is, he always likes to join. It's another story that he cannot join always because of his busy schedule. But I have seen this keen interest in him. And that's what is actually driving this program forward. Thank you very much, Parag.
Thank you. Thank you so much.
Yeah.
So,
Thank you. Thank you so much, Parag sir. I think our chairperson, Dr. Parag Vinula sir, is always instrumental. And as Ashish sir said, he always makes himself sure every time in the beginning, but today he was extremely busy. Still, he couldn't make and at least address his encouraging words. Now, shall we go to sir to the next session?
Yes.
Yeah. So next session is an important session, at least although in the 3.5 years, this case discussion we are having for the first time in during this time. And I am sure this will be an important case. The students are from VMMC and Safdarjung Hospital, New Delhi. The students are Dr. FOGSI Dhanaji and Dr. KP Apurva. And they have been very effectively guided by their professor, Madam Dr. Samitra Bachani. Dr. Samitra is professor at VMMC and Safdarjung Hospital, New Delhi. Now we have an expert panel of faculties, including Dr. Ashish Mukhopadhyay sir. Sir is principal and professor at CSS College of Visual Child Health, Kolkata, West Bengal. Then we have again experienced Dr. Jaya Chaudhary. Madam is professor at Mahatma Gandhi Medical College, Jaipur. We have another expert in Dr. Subhash Biswas sir. Sir is ex-professor and HOD, IPGMR, and presently principal, PKG Medical College, Kolkata. And then we have our own ICOG Governing Council member is Dr. Poonam Goel, madam. So I'd like to request the students to share your slides and start presenting after introducing yourself. And I would also request to faculties to take over, please. Those are examining the students.
Over to Hafiz, 1 minute.
Yes,
1
sir.
minute. Before they load their slide and they share their screen, just to inform our students and everyone that the recording of these programs are available on the website of ICOG, and all the previous program recordings are also available on the ICOG website. So you can visit ICOG website to get your revision done on the subjects and the topic. If you are missing something, so you can visit our website, that is ICOG website, and then you can go through the recording and try to recapitulate your lessons, whatever you have seen, or if you have not seen earlier, you can still get advantage out of those. So thank you very much.
Thank you so much, Ashok sir. So now I'd like to request by Dr. FOGSI and Dr. Apurva, and I would also request to faculties to examine the students. Over to you, students, and to our respected faculties, please.
Yes, very good afternoon. Obviously, this is exam situation and the stage is already set by Dr. Hafizur Rahman, then Dr. Ashok Kumar, and Ashish is always there as your examiner as well as the organizer. So, my dear students, you are going to face the examiner. Okay, in a way that is the practical real life situation in your examination. So you have to take it seriously, but don't be afraid. Very easily you can go through and pass through the exam if you are relaxed rather than being tense. Okay, so that's the way. Don't forget at this moment whoever is coming in front of you and crossing you. You go simply the case presentation as you do in your daily or round. Okay, carry on.
Yes, sir.
Please
Good
go ahead.
morning, sir. Shall I start?
Yeah, please go ahead. Start.
Sir, I'm Dr. Apurva from VMMC Safdarjung Hospital.
I'm Dr. Bhagyashree from Safdarjung Hospital.
We are going to present a case on cardiac disease in pregnancy. Presenting the case of Mrs. X, 27-year-old, educated up to 12th standard, homemaker by occupation. She's a resident of Sangam Vihar, New Delhi. She is Muslim by religion. She belongs to lower socioeconomic status by modified Kopuswamy classification. She is primigravida. Her last menstrual period was on 25th of August 2024, making the expected date of delivery on 1st of June 2025 with a gestational age of 35 weeks, 6 days. She's a booked case at Safdarjung Hospital. Her first visit was at 6 weeks. Total number of ANC visits were 9, and we have examined the patient. The date of admission was on 30th of April 2025, and we examined the patient on the same day. Chief complaint, she's a known case of rheumatic heart disease with mitral valve replacement 6 years back. She was on oral anticoagulant. She was advised for admission for switching over to an injectable anticoagulant at 35 weeks, 6 days gestation. History of presenting illness, she was admitted to the antenatal ward at 35 weeks, 6 days for switch over to injectable anticoagulant. She is appreciating adequate fetal movements. There is no complaints of breathlessness, palpitation, syncope, chest pain on exertion, orthopnea, paroxysmal nocturnal dyspnea, swelling of bilateral lower limbs, or cough with expectoration or hemoptysis. There is no history of bleeding per rectum, hematuria, epistaxis, or bleeding from any other site. No history of pain abdomen, leaking per vaginum, bleeding per vaginum, headache, blurring of vision, epigastric pain, fever, or dysuria. Coming to the history of present pregnancy, first trimester history. It was a spontaneous conception. Urine pregnancy test was positive at 15 days overdue. Her first antenatal visit was at 6 weeks. She received folic acid supplements in the first trimester. There is history of drug intake for cardiac disease in the past 6 years. And she continued the same medications in the first 6 weeks of pregnancy. She took tablet aspirin 75 mg daily, tablet acetrom 5 mg daily, and injection penidura every 3 weekly. She was switched to injectable anticoagulants at 6 weeks. NT-NB scan and dual marker test was done at 12 weeks and it was told to be normal. She continued regular cardiology visits every month, and 2D echo was done at the first visit, which was normal. There was no history of excessive vomiting, nausea, abdominal pain, fever with rash, spotting PV or bleeding PV, dysuria. There's no history of any other drug intake, radiation exposure. No history of breathlessness, palpitation, syncope, or swelling of bilateral lower limbs.
So
Second
when
trimester.
when the anticoagulation was started, and what was the indication?
Sir, she was a known case of rheumatic heart disease. She underwent mitral valve replacement with mechanical valve, for which she was started on anticoagulant after surgery.
During pregnancy or prior to pregnancy?
Sir, she was started prior to pregnancy.
Okay, carry on.
And she was maintaining the INR within the target range. And then we switched over to injectable anticoagulant.
Okay, carry on.
The second trimester history, she perceived quickening at 5th month. She was switched over from an injectable anticoagulant to tab acetrom 5 mg at 13 weeks. She received 2 doses of tetanus immunization at 16 weeks and 20 weeks. There is history of intake of iron and calcium supplements. Her level 2 ultrasound was done at 20 weeks and it was told to be normal. She continued regular cardiology visits every monthly and was advised to increase the dose of tab acetrom to 6 mg as she was not maintaining the target INR. At that time, it was less than 2, and since the dose was increased, there was no history of breathlessness, palpitation, chest pain, syncope, swelling of bilateral lower limb, no history of headache, epigastric pain, blurring of vision, leaking per vaginum, bleeding per vaginum, pain abdomen, fever, or dysuria. Third trimester history, patient is perceiving adequate fetal movements. She continued her iron and calcium tablet supplements. Growth scan was done at 32 weeks, which was suggestive of fetal weight less than 10 centile, and she was followed up with weekly Dopplers, which was normal. Interval growth scan was done at after 3 weeks, which was suggestive of fetal weight less than 10 centile. She is admitted currently at 35 weeks, 6 days for switching over from oral to injectable anticoagulants. Her menstrual history, she attained menarche at the age of 14 years. She has regular cycles at an interval of 28 to 32 days for a duration of 5 to 7 days. There was no history of dysmenorrhea or passage of clots. Obstetric history, she's been married for 1 year. It was a non-consanguineous marriage and she's a primary gravida. Past history, patient was apparently well 7 years back when she developed breathlessness on exertion, swelling of bilateral lower limbs and joint swelling, for which she was admitted in cardiology ICU at Safdarjung Hospital, and then she was diagnosed as rheumatic heart disease with severe mitral regurgitation. She underwent mitral valve replacement with mechanical valve 6 years back for the same. Her intraoperative period was uneventful. She was started on the medications like tablet acetrom 5 mg daily, tablet aspirin 75 mg daily, and injection Penidura every three weekly from the past 6 years. She continued regular cardiology consultation, and there was no history of breathlessness, palpitation, chest pain, syncope, high-grade fever, or any prior admission in the past 6 years. There is no history of diabetes, hypertension, asthma, tuberculosis, thyroid disorders, or seizure disorders. Family history, there is no history of cardiac disease in family, no history of tuberculosis, diabetes, hypertension, asthma in the family. Personal history, there is no known allergies or addictions. Functional history, patient has regular bowel and bladder habits, normal sleep pattern, and normal appetite. Dietary history, she is predominantly non-vegetarian. By 24-hour recall method, her total calorie requirement was 2,250 kilocalories per day, and her intake was 1,800 kilocalories per day, which is making the deficit of 20%. And her total protein requirement was 76 grams per day, and her intake was 60 grams per day, making the deficit of 21%.
Coming to general physical examination, she is conscious, cooperative, and well-oriented to time, place, and person. Average build, moderately nourished. Her height is 162 centimeters. Her pre-pregnancy weight was 60 kg, making her BMI 22.6 kg per meter square. Her weight gain in pregnancy was 8 kgs. Her pulse rate was 88 beats per minute, regular rhythm, good volume, no radial or radiofemoral delay. All peripheral pulses are held. Her blood pressure was 100 by 60 millimeters of mercury, measured in right arm in sitting position. Her respiratory rate was 14 cycles per minute. Her saturation was 97% at room air. Her JVP was 2 centimeter, and her temperature was 98.6 degree Fahrenheit. No pallor, icterus, cyanosis, clubbing, pedal edema, or palpable lymphadenopathy. Her orodental hygiene was fair. No visible or palpable neck swelling appreciated. Bilateral breast shows normal changes of pregnancy. On cardiovascular system examination, on inspection, precordium appears normal. Apical impulse was not visible. A transverse scar of 4 cm just below the right breast, and another scar of 2 cm present just over the sternum. On palpation, apex beat is palpable in fourth intercostal space, 1 cm lateral to mid-clavicular line. No palpable thrill or parasternal heave appreciated. On auscultation, her heart rate was 88 beats per minute, regular in rhythm. On mitral valve auscultation, S1, S2 heard. A metallic click was heard along with the S1, and no murmurs were there. On tricuspid area auscultation, S1, S2 heard. A metallic click was heard along with the S1, and no murmurs. On auscultation of aortic and pulmonary area, S1, S2 heard, and no murmurs were there. On respiratory system examination, bilateral air entry was equal with normal vesicular breath sounds. No added adventitious sounds were heard. On central nervous system examination, her higher mental functions were normal. No motor or sensory neurological deficit. Cranial nerve examination was normal. On perabdominal examination, on inspection, abdomen is uniformly enlarged. All quadrants were moving equally with respiration. Umbilicus was central and inverted. Linea nigra and stria gravidarum were seen. No scar marks or dilated veins over the abdomen. All hernial sites were free. On palpation, her fundal height was corresponding to 32 weeks, which was 4 weeks less than the corresponding period of gestation. Her symphysiofundal height was 31 centimeter, 5 centimeter less than the corresponding period of gestation. Her abdominal circumference was 32 inches. On fundal grip, broad, soft, irregular mass was felt, which was suggestive of breech. On lateral grip, on right side, smooth, curved, broad part was felt, suggestive of back. On left side, multiple knob-like irregular parts felt, suggestive of limbs. On first pelvic group, smooth, hard, ballotable, globular mass felt, suggestive of head. On second pelvic group, both the hands were converging, suggestive of head not engaged. Uterus was relaxed, liquor seems reduced, and estimated fetal weight was clinically 2 kgs. On auscultation, heart sounds were heard in the right spinoumbilical. Fetal heart sounds were heard in the right spinoumbilical line, 144 beats minutes, regular. On local examination, external genitalia appears healthy. Coming to summary.
My patient is Mrs. X, 27-year-old, primigravida, at 35 weeks, 6 days of gestation in a non-consanguineous marriage belonging to lower socioeconomic status, was admitted on 30th of April 2025. She is a known case of rheumatic heart disease with mitral valve replacement with mechanical valve. 6 years back, she was admitted to the antenatal ward for switchover from oral to injectable anticoagulant. There was no history of breathlessness, palpitation, syncope, chest pain, orthopnea, cough with hemoptysis or fever. About 7 years back, she developed breathlessness, swelling of bilateral lower limb, joint swelling, for which she was evaluated and diagnosed with rheumatic heart disease with severe mitral regurgitation, for which she underwent mitral valve replacement with mechanical valve. She was started on tab acetron 5 mg daily and tab aspirin 75 mg daily, injection Penidura every 3 weeks. There was no history of exacerbation of symptoms or prior hospital admission in the past 6 years. She is a booked case, and her first antenatal visit was at 6 weeks, at which she was switched over from oral to injectable anticoagulants. She received folic acid supplements, dual marker test and NT-NB scan were done. She was switched over to oral anticoagulant at 13 weeks of gestation, and the dose of tab acetron was increased to 6 mg as she was not maintaining the target INR in the second trimester. She received 2 doses of tetanus immunization. She took iron and calcium supplements. Her level 2 ultrasound was done at 20 weeks and was normal. Growth scan was done at 32 weeks and 35 weeks, suggestive of fetal weight less than 10 centile with normal Doppler parameters. She has calorie deficit of 20% and protein deficit of 21%.
On general physical examination, she was alert, conscious, cooperative. Her BMI was 22.6 kg per meter square. Her pulse rate was 88 beats per minute, regular rhythm, and blood pressure was 100 by 60 millimeters of mercury, and respiratory rate was 14 cycles per minute, 97% saturation at tumor, and her GVP was 2 centimeter. No pallor, sinuses, clubbing, or pedal edema seen. On cardiovascular examination, apical impulse was felt at 4th intercostal space, 1 centimeter lateral to the midclavicular line. S1, S2 heard and metallic click heard along with the S1 in mitral and tricuspid area. No murmurs. On parabdominal examination, on fundal height, her fundal height was corresponding to 32 weeks and symphysiofundal height was corresponding to 31 centimeter, which was less than the corresponding period of gestation, and her abdominal circumference was 32 inches. Single live fetus in longitudinal line, cephalic presentation, head not engaged, fetal heart sounds 144 beats per minute, regular rhythm, situated on right spinoumbilical line. Uterus was relaxed. Liquor seems reduced. Clinically estimated fetal weight was 2 kg. Coming to provisional diagnosis, Mrs. X, 27-year-old primigravida at 35 weeks, 6 days of gestation with rheumatic heart disease with mitral valve replacement with NYHA grade 1, not in failure, with single live intrauterine fetus in longitudinal line with cephalic presentation with small for gestational age, not in label.
So,
Okay, thank
what
you.
was the reason to
Yes.
shift her on the oral? What was the reason to shift her on the oral anticoagulants when you had already put her on the low molecular weight heparin at 6 weeks?
Ma'am, the risk of thromboembolic event with low molecular weight heparin is 9%, whereas the risk of thromboembolic event with oral vitamin K antagonist is around 4%. So for the mother, it is safer to give oral anticoagulant.
Okay. And cost, I think, is also one of the
Yes,
reason can be.
cost
Yes.
and multiple injections.
Monitoring also.
Monitoring
Yes,
also. That is
monitoring
very
also.
important. What you will use for monitoring whenever she is on oral anticoagulant and whenever she has injectable anticoagulant?
Sir, for oral anticoagulants, we use PT and INR. And for injectables, like for low molecular weight heparin, we use anti-10A factor anti-10A levels. And for unfractionated heparin, we use APTT.
Okay. And what is your target level? You have repeatedly told twice that the target INR. What is your target INR?
So between 2.5 to 3 for our patient. The valve that was replaced was low it has low thrombogenicity, sir. That is why we are
Why it
Sir,
is low thrombogenic?
Sir, I saw the discharge paper of the patient for the operation that she underwent 6 years back. It was St. Jude's valve, which belongs to low thrombogenic valve, sir. So we are keeping the target as 2.5 to 3.
What is
So
the
how
main
does
difference? Yes, ma'am. Please carry on.
how does this anticoagulant works, acetrom? Mechanism of action, how does this work?
Ma'am, it inhibits vitamin K epoxide reductase, which is responsible for the activation of clotting factors 2, 9, 7, and 10. So when we use this, there is inhibition of that activation, so anticoagulation is achieved.
And how does unfractionated heparin act?
It inhibits 2A thrombin directly as well as 10th factor, sir.
What is the difference with low molecular weight heparin in mechanism of action?
So low molecular weight heparin acts on antithrombin 3. It forms a complex and inhibits activation of factor 10.
Okay. And which one is safer between the two?
Between the low molecular weight and low molecular weight heparin and unfractionated heparin, the low molecular weight heparin is safer, as it does not as the risk of thromboembolic event is lower compared to unfractionated heparin, sir.
What is the dose frequency?
And for low molecular weight heparin, it is 1 mg per kg twice daily.
Okay, and unfractionated?
For unfractionated heparin, we can either give subcutaneous dose or IV infusion. For subcutaneous dose, we divide it in twice daily doses, around 5,000 units in each dose. And or if we are giving IV infusion, we give 80 units bolus, 80 units per kg bolus, and 18 units per kg per hour infusions.
Okay.
So what is the cause that you changed it in the first trimester to low molecular weight heparin? What was the reason?
The risk of we are using acetrom, ma'am. If we use acetrom in the during organogenesis period, there is the risk of embryopathy if we give more than 2 mg per day. As we are giving 5 mg per day, hence we explained the patient about the risk of embryopathy. We have offered her both unfractionated heparin, low molecular weight heparin, as well as the acetrom. She chose that she wants to continue the low molecular weight for 6 weeks.
So what embryopathy can happen?
Nasal hypoplasia, stipple.
Yes.
Basically it affects the cartilage formation. Nasal hypoplasia, choanal ectasia, as well as stipple epiphysis can occur.
Limb defects can also occur.
Yes, limb defect.
Typically termed as warfarin embryopathy.
Embryopathy.
Yeah, warfarin. Ajay, you have told about the patient is suffering from rheumatic heart disease.
Yes,
and had undergone mitral valve replacement. But what was the lesion? That is not clear from your presentation.
Sir, she had severe mitral regurgitation, sir.
Okay.
And that is why she underwent valve replacement.
Okay. What is the indication of mitral valve replacement? In stenosis or in regurgitation? Whatever it is. What is the indication?
Severe mitral regurgitation is an indication for mitral valve replacement, as well as severe mitral fibrosis or severe calcifications. And left atrial thrombus, even after giving anticoagulant therapy, if there is persistent left atrial thrombus, we will have to replace the valve.
Okay.
So if at all a patient has a lesion like mitral stenosis or regurgitation, which one is better for a pregnancy? Out of these two.
Regurgitant lesions are better tolerated. During pregnancy, there will be decreased systemic vascular resistance, which leads to decreased regurgitant flow.
So there is decreased afterload. That is why. Okay. So physiology of changes in all this cardiovascular system in pregnancy.
The plasma volume starts to increase by 6 weeks, and it reaches maximum at the end of second trimester up to 40 to 50%. And the heart rate increases by 20%. It can reach up to 15 to 18 beats per minute. The stroke volume increases by 30 to 50%, maximum at 32 weeks. And hence the cardiac output also increases from first trimester and reaches maximum at 32 weeks. And it also increases during the labor up to 50% the baseline, and also the highest at immediate postpartum.
What is the importance of knowing these changes in your cardiovascular changes, particularly in this case? What is the importance of knowing that?
There are 5 critical phases in the heart. There are 5 critical changes in the cardiovascular system during the pregnancy. At 6th week, at 32 weeks, during labor, second stage of labor, and immediately postpartum. At this stage, there is risk of increased risk of failure, sir.
So during puerperium, in the end of first week or the beginning of the second week, late puerperium, they are also at risk. What is the reason behind?
So there is shift of fluid from the extravascular compartment to intravascular compartment, which increases the preload and can lead to failure.
Yeah.
So that is the reason that whenever a patient who is normal, like not your patient, any patient who is coming at 24 or 26 weeks and complaining of breathlessness at that particular point, so we must evaluate the patient for the heart condition.
How will you start evaluation a patient in the antenatal ward? You have got a patient with heart disease in pregnancy. How you will counsel and start or plan your management?
If she has come, she has
come for the first time. Yeah, she has come for the first time. You have come to know she is a case of heart disease, and how will you plan your management?
In the antepartum period, we'll take the detailed history. Then we'll examine the patient for signs and symptoms of the failure. Then we'll investigate her. First, we'll do all baseline investigations. Along with that, electrocardiogram and baseline 2D echo we'll do. Based on the
I didn't ask you how you will do that. I have asked you how you plan. That means the patient has come. You have to establish the diagnosis. You should know the preconception, any intervention. Then you have to know the functional status of the patient. Then you have to go for risk stratification according to WHO and all. Then you confirm your diagnosis by investigations, whatever you need, and antenatal management, how frequently she should come, what the complications she is arising, for which complications will lead to admission of the patient, how will you tackle that? And then lastly, the 2 questions are must: when you are planning to deliver and how you will plan to deliver. So whenever you have been asked in the examination, the patient has come, how you will start your planning of management. And the first line should go like that: said it needs multidisciplinary approach. So we should have a combined clinic of both obstetrician, cardiologist, as well as other people who are committed. Okay. Yes, carry
So
on.
in these particular patients, preconception counseling is very important. So
Yeah.
whenever such patient comes, we must do that.
Yes. First, it is a multidisciplinary approach. It consists of pregnancy heart team, which consists of senior obstetrician, senior anesthetist, and a cardiologist. Then we'll assess the functional status by NYHA grading. Then we'll have to risk stratify based on the WHO category. There are 5 categories: Class 1, Class 2, Class 2 to 3, Class 4, and Class 3, and Class 4. and we have to explain the patient about the cardiovascular complications, which is 0.5 to 5% in class 1, 5 to 10% in class 2, 10 to 20% in class 2 to 3, 20 to 40% in class 3, and 40 to 100% class 4. After risk stratification, we have to do the 2D echo and assess the anatomical lesion of the patient. If she requires intervention, it should be. Yes.
Hello, excuse me. In your case, what is the risk stratification in your case? Because it is
Which
easy to
class?
say, yeah.
So she belongs
Tell
to WHO class 3 since patient has valve replacement of mechanical valve.
Yes.
Okay. And what is the risk?
So the risk is around 20 to 30%.
So risk stratification is necessary. For
Yes,
what
sir.
purpose? For what is the purpose of doing this risk stratification?
Sir,
One is to counsel the patient as well as to know the obstetrician regarding the further complications of the disease and requirement of the hospital admission, frequency of the visits also. She has to know the frequency of visits to the cardiologist as well as the
Yes.
obstetrician.
Absolutely. So planning of your visits, how frequently and by whom. So that is more important, and what investigations you might need and when to admit the patient. Okay. That is the reason behind it.
What can be the cause of FGR in your patient?
She is
Everything
belonging
was
to.
going well.
Yes, ma'am. She is belonging to lower socioeconomic status. That is also one cause. And another cause is her weight gain during pregnancy is less than the target, which was 10. For her, 10 to 12 kg weight gain is normal, but she has achieved only 8 kg weight gain.
So she was 35.6 weeks when you did the scan, and
Yes.
what you found was that Doppler was normal,
Yes.
but the weight and etc. was less than, I think, 10%.
10 cent. Yes.
10 centile. Okay. So now when will you repeat, or how will you manage your patient?
Ma'am, we plan for termination for small for gestational age at 38 to 39 weeks in our hospital. So since patient was already on oral anticoagulant, we shifted the patient. We switched the patient from oral to injectable anticoagulant. We started her on low molecular weight heparin, enoxaparin 60 mg BD dose, and then we monitored the anti-10A levels daily until the target was achieved, which is for her.
What is the
since
normal
it is-
anti-10A level?
Sir,
0.4.
0.4 for her. Since we're giving low molecular weight heparin and it is a mitral valve replacement, we keep the target as 1 to 1.2 units per ml, and we monitor the patient till daily anti-10A levels are monitored, and then we repeat it weekly. Then just 36 hours before delivery, we switch the patient from low molecular weight heparin to unfractionated heparin. We give 18 units per kg per hour infusion, and then repeat APTT every 6th hourly to achieve the target 2 times the baseline APTT value. And we stop unfractionated in our patient since she was WHO class 3 with NYHA grade 1. We prefer vaginal delivery for our patient. At 38, we did vaginal delivery at 38 weeks. So we stopped unfractionated heparin infusion 6 hours before delivery, and we assessed the pelvis, and we did Bishop's scoring. Bishop's was unfavorable, so we induced the patient for cervical ripening with dinoprostone gel and reassessed the patient after 6 hours. And then Bishop's was favorable. We started the patient on injection oxytocin augmentation. We give concentrated oxytocin to avoid volume overload. And in the
What is
first
how will you
Now,
start oxytocin?
in the infusion, with the help of infusion pump, we give concentrated oxytocin starting from 2 MIU per minute.
And we'll titrate according to
To
the
the
contractions.
Okay. So for 2 MIU in bottle, how much oxytocin you will add?
In 50 ml, in 50 ml syringe, we'll add 3 international units and we'll start 2 MIU per minute. It will be 1 MIU per minute.
What will be the drop of
So
fluid?
for 4 MIU, it is equivalent to 2 units, 15 drops infusion. If we
Okay.
give it in the 500 ml vac, it will lead to volume overload. To avoid volume overload, we prefer giving it in infusion pump in our patient.
Okay. You give infusion pump.
Yes.
Okay, that's good. Yeah.
So how did you monitor the fetus from your 35.6 to 38, 39 weeks? What all
Ma'am-
you did in between? You did scan or NST, CTG, what you did?
At 32 weeks, we got to know that weight was less than the 10th centile. Then we planned every weekly Doppler and bi-weekly NST. Then at 35 weeks, we again did the interval growth scan. It was again less than the 10th centile. Then we again did the weekly Doppler till the delivery, till we planned the induction. Till that time, we did the weekly Doppler and bi-weekly NST. As she was admitted on at 35 plus 6 weeks, she was in hospital. So we did NST daily now.
Okay.
So
She is a diagnosed case of FGR at 28 weeks. How you can take any other measure to improve upon?
Sir, in our patient, she was actually diagnosed at 32 weeks. It was late onset FGR. So we monitored with ultrasound Doppler and biometry after every 3 weekly. We did
Suppose she had,
No,
suppose
sir is
she has
asking
come
about
to you at
management.
28
What
weeks.
else you can do?
Sir, we can do DB Doppler for early
The
onset.
Doppler, only daily Doppler will help you to diagnose, but how to improve upon the outcome
Improve
of the
management.
fetus management?
How to treat? Can we?
We have basic. There are many trials of giving nutritional supplements as well as sildenafil therapy, but nothing is superior. Nothing was superior. So we only advised for monitoring, dietary improvement, nutritional improvement as well as monitoring.
Okay, so empirically you can add something for the nutritional benefit. What do you use anything in your hospital?
So, sir, we don't advise any nutritional supplements. We'll advise the diet. We'll advise
to
Only
increase
the
the
improve the
calorie
diet.
intake and
We'll
protein.
take the opinion of nutritionist and increase the calorie intake.
Okay. So do you want to exclude any pathology of placenta at that moment?
If she is early onset FGR, we can
Yeah.
offer the patient. If we can offer the patient torch profile as well as karyotype microarray. Sir.
So you are proceeding to deliver the case as Madam asked you at 36 plus weeks by induction, or 37 weeks or 38 weeks by induction. Induction, okay. So 38
sir.
weeks. You are
Yes, sir.
choosing the time for 38 weeks.
Yes,
Okay.
sir.
So during labor, interpartum monitoring is essential. That is true. But what are the indication of cesarean section in that case, apart from obstetric indication?
Sir,
Or only you do for obstetric indication?
sir, there are cardiac indications like in case of severe aortic pathologies like aortic root dilatation in Marfan syndrome more than 45 mm, and in bicuspid aortic valve more than 50 mm, and also severe coarctation, severe symptomatic aortic stenosis, severe MS and NYHA grade 3 and grade 4 conditions with ejection fraction less than 30%, and PPCM with residual heart defect. And also in case if the patient is on oral anticoagulant for less than 2 weeks period.
But in your case, that is not the lesion, or
No,
that
sir.
is not the
She
severity.
was
So you are expecting vaginal delivery.
Vaginal delivery for our patients.
Okay.
So has the patient delivered?
Yes,
Yes, ma'am.
yes, ma'am.
She has delivered.
So was it a vaginal delivery?
Yes, ma'am. It was a vaginal delivery.
And what was the birth weight of the baby?
1.9 kg, ma'am.
Oh. So what postpartum management in these scenario, your patient in cardiac patient?
Ma'am,
Anything extra?
Ma'am, in the immediate postpartum period after managing the third stage, we gave injection furosemide 20 mg prophylactically to reduce the preload as there is increase in the auto transfusion from the uterus and also sudden release of IVC compression, which
So did
increases.
you use carbitocin or oxytocin in your patient?
Ma'am, we used oxytocin in our patient.
Oxytocin. Okay.
Okay, that's good. I am going back a little bit. How will you do the management of first stage?
So during the first stage, we keep the patient in the semi-recumbent position with lateral tilt, and we monitor the vitals every 30 minutes. We monitor her BP, pulse rate, saturation, and also respiratory rate. We do frequent chest auscultation, and we'll also do the input-output monitoring every 4 hourly. And then for analgesia, we prefer epidural analgesia since in our hospital it was not available. We gave opioid analgesics like tramadol for the pain relief, and we continued as the patient goes into active labor. We monitored the labor progression in the modified WHO partogram.
So at the same time, not only the fetal monitoring, maternal monitoring is very important. In this case, you apprehend cardiac failure. You apprehend cardiac failure. How you will diagnose heart failure at this moment?
So if the pulse rate is more than 100 beats per minute, if the respiratory rate is more than 24 beats per minute, and if the patient is if the saturation is dropping, and if there are basal crepitations, we suspect heart failure.
So to start with, breathlessness, palpitation. Okay. Yes. Sometimes syncopal attacks. So that is the first. You always jump over the examination and investigations, but first start with the symptoms for which she will seek your advice. Okay. In that case, suppose she had gone into heart failure, how will you manage?
First, we'll give oxygen therapy, sir. Then we'll give diuretics to decrease the preload. Injection.
So first you will call your cardiologist.
Cardiology.
Okay, that is the main thing you forget. So you are not the cardiologist. First thing, once you have uttered the first thing means what will you do for the first time? The first thing is to inform your cardiologist. Okay, then you carry on by this time. Yeah.
I think whenever such patient is admitted, the reference should be there to cardiologist. That, and they should be updated that such and such patient is there.
Okay. Are you going to digitalize this patient at that moment?
No, sir. If the patient is not improving with IV furosemide, and then only we think of giving other medications like digoxin, and to control the heart rate, we can give metoprolol.
After taking the
Beta blocker. Okay.
For them to decide.
In first stage, anything else you want to do for the management part? Madam had drawn you to postpartum. So before that, I told you in labor. In labor, one thing is okay, apprehending cardiac failure, monitoring the patient, and anything else you want to do in your case?
To reduce the analgesia, we give analgesics. We prefer giving epidural analgesics as it can precipitate the heart failure. And
in which
also
cardiac lesion? In which cardiac lesion? This is mitral valve. Okay, accepted. In which cardiac lesion you want to avoid epidural analgesia?
Sir, in aortic stenosis, we avoid giving epidural analgesia as it causes hypotension and decrease in the peripheral vascular resistance, which can reduce the preload.
Okay. And accepted. In your case, in the first stage, anything else you want to do in your case?
Continuous fetal monitoring.
Okay, that is the obstetric part. Anything? Do you want to do something against bacterial endocarditis?
Yes, sir, since patient has
Already taken.
mechanical valve, we
Yeah.
give antibiotic prophylaxis. We give injection
So
ampicillin 2
why you are
gram
not
twice.
coming up? Why you are not coming up with your management? 3 times I repeated. What else you will do? Is not that very important part of the management?
Yes, yes.
Okay. If you have been asked in the examination when the bacterial endocarditis will be given, prophylaxis will be given, what sort of medicine will be given, then you can answer. But given scenario in the management, that will come spontaneously from your part. Okay, this
Yes.
is the management also I will offer.
Yes.
Clear? What are
Yes.
the indications of, in your case, okay, it is valve prosthesis. And what are other indications of giving bacterial endocarditis prophylaxis?
Sir, one is prosthetic valve. The other one is
Yeah.
there is history of, if there is previous history of infective endocarditis, and in case of cyanotic congenital heart disease, which is unrepaired, or if it is repaired with a prosthetic material, for the initial 6 months we give antibiotic prophylaxis. And if it is a repaired congenital heart disease with residual defect, again we give antibiotic prophylaxis. And a rare condition is heart transplant with valvulopathy. We prefer giving antibiotics.
How does the very good? What antibiotics you usually will give?
Sir, in our hospital, we give injection ampicillin 2 gram IV stat dose. And also we can give injection ceftriaxone, cephalexin, or azithromycin, clindamycin.
Okay. If it is allergic to penicillin.
Penicillin
Then
group,
you
we
can-
can give
okay.
clindamycin.
Okay.
Your patient was taking penicillin regularly.
Yes, ma'am. She was taking Penedur at 3 weeks.
How frequently you give Penedur?
Sir, if it is injection, we give it every 3 weeks.
Every 3 weeks. Because I asked some books, some textbook you follow or you read, they have written 4 weeks, but every 3 weeks is the standard. Okay.
3 weeks.
And some textbook you follow sometimes has quoted plus gentamicin, but gentamicin is not recommended by the ACOG, no?
Yes,
It is
sir.
not,
ACOG recommendation is only ampicillin
Only
or
ampicillin.
other.
Yeah.
as you throw.
So she has gone into second stage. How will you manage the second stage?
So during second stage, continuous vital monitoring has to be done, and continuous fetal monitoring has to be done. And we cut short the second stage using prophylactic forceps delivery for our patient.
Which one is better?
Position you put the
Prophylactic.
patient in?
Sorry, sir.
Which position?
Position.
In
Patient
second
will deliver in semi-recumbent position only, sir. And with the legs below the bed level.
Suppose she wants and she says that I'm comfortable in turning backwards and staying on my forelimbs. Will you allow that? Is that any extra load on the heart?
No, sir, it can be allowed.
So let her be in her comfortable position.
Yes.
If today's train, heart disease or no heart disease, we always allow the patient to deliver in
her comfortable position.
Comfortable position, right?
So
And
forceps,
prophylactic administration
yeah,
of
yeah.
forceps, is it very accepted these days?
Sir, if the patient is getting good contraction and if she is able to push by herself without any vitals, if the vitals are normal and patient is stable and she can continue normally, if she is pushing, if she is going for prolonged second stage, then it is better to use forceps.
So if you want to assist her to hasten the delivery, which assisted vaginal delivery is better, forceps or ventouse?
Or ventouse.
So forceps is preferred because it does not require maternal effort for the delivery. In case of ventouse delivery, it requires maternal effort also along with the traction. So that can also cause increased risk of failure for the patient.
In terms of assisted quotient, assisted raised a point of position of the patient. In that aspect, which one is better?
It is better to deliver in sitting or semi-recumbent position, sir. But
In that case, even in standing, whatever it is, the ventus is easily applicable.
Ventus is better.
Okay, so you come back to the summary of your case presentation. Just go back to the summary.
yes,
I think the summary is a bit long, and
Yes,
you
sir.
need
She
to,
had.
need to make it concise. It's a summary. You have, as if you are presenting the case all over again, and you have written the valve replacement with mechanical valve twice. I don't know why. In summary, you are actually constrained for time, but you have mentioned it twice. Any particular reason for that? So RHD with mitral valve replacement with mechanical valve replacement. Once again, you have written diagnosed with rheumatic heart disease, mitral regurgitation, for which he underwent mitral valve replacement. So avoid this, repetition of, because you are pressed for time, and you have
yes,
to
sir.
finish within a certain period of time. Next slide, you go. Yeah. So this is
Yes, too long.
shortened, and I think the next slide will show.
Examination.
Go to the next slide. Yeah, this is too much of detail. You have already mentioned and kept it in your sheet. All
Yes,
these
sir.
reported findings. Okay, it's so much of details. Remember, you have to say this extempore to the examiner, because the
Yeah.
sheet is taken away by the examiner. How can you remember so much of data when people tend to forget their own names during examination?
Yes.
Ashish sir has raised a very valid question, what he hinted in my brain also, that your summary needs to be summarized.
Hmm.
It is too
Yes.
long. It
Yes.
is too long. You don't do this.
Hmm.
Your idea in the examination is to pull your examiner or drag your examiner to the case itself. More and more you devote in your case presentation, there are two risks. One risk is you are cutting your time to show your knowledge on the subject, and another thing, you are putting unnecessary some sort of obstacles to you. How? He may ask on again on diet, he may ask on your calorie requirement, he may ask on more and more. You pass on all this problem, that is better for
Yes.
you, because you are at this moment very much knowledgeable regarding your case. So better to drag the examiner as soon as possible to the case discussion, rather than just waste your time in your case presentation. Okay.
So
Very
time is
clear cut
limited.
concept. Very
Time
important.
is limited, and it's precious for you, not so precious for the examiner, but it's very precious for you, isn't it? So I
Yes.
think that you keep the data to a minimum, something which is presentable, something which you can remember, and something which is worth listening to is what the examiners want. What is happening? You are theoretically very sound and you know your subject very well, but then the presentation, go to the next slide, please. Yes, provisional diagnosis. Now, my question is, when you write cephalic presentation, do you need to write longitudinal line? Ask yourself. Have you seen any cephalic presentation with transverse line?
Yes.
We haven't seen, right? So
Yes.
these are small little questions, that factually you are correct. But then presentation of a case, which should show that you are equally involved in the case, in managing the case. The purpose of the examination is to see that you are independently capable of managing this woman when you come out of the institution umbrella, right? That is why what the examiners have come to assess. Anyhow,
Yes.
these are my small suggestions that you should improve upon.
And this, like NYHA grade 1, then not in failure needs not to be written.
Okay. Yes.
Absolutely.
So I
And
think
the postpartum we were talking, anything special you will do in this patient?
Ma'am, postpartum contraception, ma'am.
Which
Then
is the best contraception?
we'll restart the anticoagulation for her
When?
after. Ma'am, this for our patient, we restarted after 6 hours. We restarted
Okay.
infractionated heparin, and we continued 18 units per kg per hour infusion. And
BCG.
then we switched over to, then we started acetylene and monitored
When do you
INR
start?
level.
When do you start
6
acetylene?
hours.
On third day, we started acetylene for our patient, and then
So you will stop infusion and add acetylene.
sir, we'll start infusion in the beginning after 6 hours, and after 12 hours we can switch to low molecular weight heparin, sir. As
Then
the sir.
then when
Then
do you start
after
acetylene?
we continue low molecular weight heparin BD dose, and then along with that we start acetylene tablet, and we wait for the target INR to be achieved. And once
No,
the
I want
target
to
INR,
mean you will finish the low molecular weight heparin and start acetylene.
no sir, we'll continue low molecular weight
That means
along
there
with
should be some overlapping.
acetylene.
That you should say. There will be
Overlap. Yes, sir.
overlapping.
We'll
of
do
both the-
overlapping
Yeah.
of oral and
Now
injectable until the
there
target is
are two things in LMWH, low molecular heparin. One is the therapeutic dose which you have mentioned, and one is prophylactic dose. Can you tell us-
prophylactic dose.
Yes, when to go for the prophylactic dose and when to go for the therapy. Is there any role of prophylactic dose in this case? Postpartum?
Yes, sir. Yes, sir. In case of if the valve is low to moderate thrombogenic, we can actually go for prophylactic low molecular weight heparin. If the weight is less than 50 kg, we can give 20 mg. And if the weight is between 50 to 90 kg, we can give 40 mg. And if it is more than 90 kg, we can give 0.5 mg per kg prophylactic dose of low molecular weight heparin.
In
And
your
then
case,
after 12 hours,
when do you propose to start this, you said?
sir, 6 hours after delivery, instead of unfractionated heparin, we can also give a prophylactic dose, and after 12 hours, we can start her on therapeutic dose.
No, I'm asking after the delivery.
Yes.
You're saying within 6 hours you will start the prophylactic dose. 6 hours.
Yes. Therapeutic. After 6 hours after delivery, we can start prophylactic dose, and 12 hours after delivery, we'll start therapeutic dose.
Both in cesarean section and normal delivery.
No, sir.
the same.
This is for vaginal delivery. For cesarean
Okay.
delivery, we start low molecular weight heparin after 12 hours.
Okay. Any any role on breastfeeding for any sort of oral
Sir,
anticoagulant?
if we are giving acetylene, there is it is secreted in breast milk in very less amount, so it is safer to go for breastfeeding in our patients.
Okay.
I think Shubhasda, we are in time to finish the case.
Yes.
Dr. Ashish, I want to ask or add few more things in this at the moment, since this slide is in front of us where provisional diagnosis has been made.
Yeah.
And it is showing a provisional diagnosis. So I want the students to tell me about two things more in this, which is nowadays coming up with the heart disease case. We want to know what is the WHO modified score for this patient.
This scoring, yes. Yeah.
She's
I
class.
think they already told.
I think that should be
Yeah,
written.
but you have to add it in the in this
in
diagnosis.
this also. Okay.
That is good. We asked,
So
but
what is
that should
what
be
is the
written here.
WHO modified score for this?
Class 3, sir. She's
3.
WHO 3.
So what does it mean? Can you describe 3?
She has
What
the
do you
risk
mean
of
by 3?
cardiovascular complications around 20 to
20
30%, and she has to visit the cardiologist every monthly, and she has to
Yes.
visit the obstetrician every 2 weekly.
And one more thing, where to deliver?
She has to deliver at expert center,
Tertiary
care center.
Yeah. So putting in the WHO score gives you a lot many insight into the management of the cases.
I
Yes,
think
right?
it should be included in the provisional diagnosis.
So
And
it should be
also the
included in the
summary.
provisional diagnosis. And
also
then
the
can you tell me something about the prognostic feature factors, like what are the scores you are aware of?
Sir, there is CARPREG, other than modified WHO scoring, there is CARPREG.
No, CARPREG score. So can you tell me what is the CARPREG score for this patient?
Sir, for our patient, it was 6. She has
So-
prior cardiac event and also mechanical valve, which is making the score 6. So the risk of cardiac complication in this pregnancy would be more than 40%.
So I want to
So
highlight
Zahara
here.
and Carpreg, any difference? There
Zahara,
is another.
Zahara scoring is for congenital heart disease and Carpreg is mainly for valvular heart disease.
Yeah, that's
So our
good.
patient is for
So
Carpreg. Okay.
So it is better if you include these two things at least
Two things.
in your provisional diagnosis, because that gives us also some more information about the patient. Number one.
I think
Number two,
WHO is okay, isn't it, Dr. Ashok Kumar?
sir, if they can tell us few more score, it is because different things gives you different information. So
But
it
not
will
in the
give a
provision.
holistic.
You recommend in the provision diagnosis only, or
Or we can, if they are not telling us in the provisional diagnosis, then we have to ask them.
No,
For discussion point of view. So if
no,
they
no,
can
Dr.
tell us
Ashok
it
has
is,
Dr. Ashok has rightly told that as we write with New York Heart Association grade on, instead of that, that should be the modified WHO risk category 3. That is
third-
better to write.
we can keep both, isn't it?
Yeah.
NYHA
yeah,
grade
we can
plus
keep
Yes,
NYHA
both,
and-
both, sir, both. Both
sir,
should be there.
at my institute, we are keeping both in our provisional
both,
diagnosis
yes, yeah.
That's
because it
good.
gives
Yeah.
us some more
Absolutely.
information.
Yeah.
So
Yeah,
one
absolutely.
more thing I want to know from the student. Now,
Yes.
because these WHO and these, I think Carpreg, they all talk about maternal factors or maternal points which affect the outcome of a pregnancy in a heart disease mother. Now, tell us some of the fetal factors which will also affect the outcome.
The conditions causing chronic hypoxia like pulmonary artery hypertension or ejection fraction less than 30%, left ventricular outlet obstruction like severe aortic stenosis symptomatic. All these will affect the placental perfusion, which can lead to FGR or SG.
You are talking about
So
the
it is
fetal-
FGR. So the fetal factor FGR will also affect the outcome because FGR may
FGR
may
can
lead
lead
to
to
IUD,
preterm delivery or
may lead to
stillbirth.
preterm delivery and all these things.
Yes.
So you have to understand this. So my point is, what I want to highlight and remind the students is that when we are talking of prognostic factors or when we talk about the prediction or predictor of outcome, what are the favorable factors or what are the unfavorable factors, we should divide them as a mother, maternal, as well as the fetal factors.
Fetal.
Because most of the books, wherever it is written, it is the maternal factors.
Maternal.
They are not highlighting the
Fetal factor.
fetal factor. As a obstetrician, see, if the patient goes to the cardiologist or to the physician, they will only see the maternal factors. They are not, but when patient comes to the obstetrician, we have to see the maternal as well as the fetal factor, means obstetric factors related to pregnancy as well, right? Where we have to see the gestational age, we have to see whether FGR is there or not, we have to see whether patient is having simultaneous preeclampsia or not, right? Simultaneously, we have to see the placental position also, because all these are going to affect our pregnancy outcome. So FGR, oligohydramnios, heart disease, and because of the hypoxia of a heart disease patient, there might be many other complications, right?
Yes,
So
Dr. Kumar, I think
always
that
remember,
they haven't added IUGR or FGR in the diagnosis. I wonder why. Because upon crossing, they revealed that they have more than 4 or 5 reasons to suspect FGR in this case.
No, they have treated with small for gestational age. They have
no, I
written
just want to
with
know one thing. I just want to clarify with the students. Your period of gestation is 35 weeks, 6 days. What is the
6 days.
fundal height of the patient? What is the fundal height of the patient?
31 weeks, they told, 32 weeks.
32 weeks.
Pardon?
they said.
Lines were not full.
So you are saying it is 32 weeks. So if fundal height is 32 weeks and period of gestation is 35 plus 6 days, what should be included in your diagnosis?
Flanks.
Pardon?
Sir,
As her flanks were not full, so we suspected the small for gestation.
like oligohydramnios.
So it should be added in your provisional diagnosis. So that is a part of your prognosis, the provisional diagnosis.
Yes.
This
that
is what
also
we
has
want
been-
to highlight, that when you are presenting your case, you think of all these components and try to complete your provisional diagnosis. You should not miss anything.
SGA is non-specific. No, you have to. I think FGR is more specific, and therefore, I think you should add. Anyhow, so
Yes.
we will now close the discussion on this case. And thank you very much, students, and thanks our faculty members for such a good interaction and so many questions and that has been generated. And as days progress, you can understand why we keep one case repetitively for the students to present, because of this evolution of the new techniques, new examiners, new point of view by the examiners as well as the students. And examiners always want to see, as Dr. Ashok Kumar said, whether there is any risk factors we are missing in the case presentation summary or provisional diagnosis that is likely to have an impact on the outcome of the mother as well as the baby. That is why that so much of crossing has been done to you, but you have passed very well. I think congratulations to all the students, and thank you very much, all our faculty members. Thank you so much. We'll now close this
Okay.
session.
Thank you.
Thank
They
you.
presented
Thank
well,
you all.
very good.
Yeah.
Very nice. Nice presentation.
Yes.
Yes, Dr. Hafizur, can you start the next session, please? Please, this screen, share screen, please off. Yes. I can see Dipannita in the audience with a traditional trademark smile. And
Good afternoon, sir. Good afternoon, Dr. Bishash, Dr. Mukherjee, Dr.
Very
Hafizur.
nice. Yeah.
Thank you so much, Dr. Dipannita, for agreeing and joining for this session. So,
Dr.
yeah,
Ashok.
this
we first
Dipannita
thank the
is.
examiners, Hafizur. They
Yeah,
have
sir.
taken so much of pain in examining the students.
Yeah.
And also,
Thank you.
thank the students also. Yes.
Yeah, thank you so much to all the students
Faculty
first
members.
initially for their having an excellent presentation, as well as all our faculty. So thank you, Dr.
And Dr.
Vaidya.
Hafiz, we should not forget Dr. Sumitra Bachani for supporting us and
Excellent,
preparing our students for the case.
Correct. Yeah.
And it was a really interesting case discussion, and lot many information has been shared and provided. So thank you, Dr. Sumitra.
Sumitra
Yeah,
is
yeah,
now silently behind the screen, and she worked like a soldier.
Yeah, yes, sir. What is I observed is Sumitra Madam is one of them, all the faculty's coordinator, who has taken very much in interest as well as guided the very students faculty. And it was more of a like Madam was no, just requesting like please give students to our students to the chance. So that was we are very much appreciating to Madam Sumitra Madam for giving your students as well as valuable time for this important topic.
Thank you, sir.
Thank you. Now welcome Dipannita and thank you.
Yeah, so we're also thankful to all the faculties. Ashish sir is there, Dr. Daya Chaudhary Madam, Dr. Subhas Visa sir, and Dr. Fonal Goyal Madam. Now we have this important session, and it's very much for this Dr. Dipannita Banerjee. She is an expert on this session, and I am sure student will be very much helpful with this session. So Dr. Dipannita is Associate Professor Gynec Oncology at Chittaranjan National Cancer Institute, Kolkata, and she will be demonstrating as well as delivering practical aspects on how to take pap smear, LVC, and HPV test. So since we are already getting lagging, I will not waste more time. Over to you, Dr. Dipannita. This session is for you.
Thank you so much, Dr. Hafizur. So I hope my screen is visible now.
Yes, it's visible.
Go ahead.
Yeah, so good afternoon, my teachers, my chairpersons, and the delegates, whoever is attending this program. And thank you, ICOG. Thank you, Dr. Ashok, for giving me this opportunity, and Dr. Hafizur. So I will restrict my talk mostly practical, and what are the tips and tricks what do you have to the students will be asked during the examination. The cervical cancer screening methods, pap smear, VIA, and HPV testing. I would like to draw the attention that this was the first publication which was done on pap smear by George Papanicolaou, published in American Journal of Obstetrics and Gynecology in August 1941, which showed the importance of pap smear, and it is more than 50 years, 70 years past, that still we are talking about this important test which is related to cervical cancer screening. So over the years, many evolutions has come across, and it has been seen
There are some connection issues, I think. Dipanita, do you have a Wi-Fi connection at your place?
I see it's showing she's connected, sir.
She's connected, but she's, the transmission apparently has stopped. That's why I'm worried whether her connection is okay or not. Dipanita, can you hear us?
Yes, sir, nuts.
There's
Sir, find out quickly.
There's some problems in the connectivity issues, network connection. Admin team, can you help us in this matter? I think
Sir, if we have some problem with her, we can find
Sir,
out if it is taking too long, then we can start the quiz.
She's joining, sir. We'll have to
I saw Archana. Yes, she's there. So we can.
No, but sir, just wait if she can start in 2-3 minutes, because students also know they have to start the quiz after 2. So we may not.
Right. Yeah, that's true. That's true. So yes, I think I can see
Sir,
Archana.
if you want, I can start, but let us
yes,
wait for
Archana,
2-3 minutes.
We understand that. Now, the point is, I will speak to I think Dipanita, if she is likely.
Sir, I have already informed her.
Yeah, I think I lost the
Okay,
connection.
you're audible.
She's here. No, she's here. She's here.
Okay, no problem. Dipanita, go ahead. Continue.
Yeah, please go ahead.
Resume.
Yes, please go ahead. Yeah.
Yes.
We can see your slides. Please go ahead.
Make it full. Yeah. Okay.
Yeah, so the Globocan 2022, the statistic shows that cervical cancer is the second most important cancer causing in India. And India provides around 1/5 of global burden of cervical cancer. So with this background, the triple intervention by 2030 and beyond, WHO call for elimination was done by Dr. Tedros in the WHO, which launched officially the global strategy for cervical cancer elimination with triple pillars 90, 70, 90, where 90% of girls fully vaccinated with the HPV vaccine by age 15. 70% of women are screened with a high performance test by 35 and 45 years of age, and 90% of women identified with cervical disease receive treatment. So with this strategy, WHO has done a mathematical modeling and has showed that if this triple pillar is strictly followed across the countries, the cervical cancer will not remain a public health problem anymore. So what are the strategies? Prevention, we all know during our community medicine days that there is primary prevention, secondary prevention, and tertiary prevention. So for the secondary prevention, primary prevention is HPV vaccine. The secondary prevention comes, the three pillars are cytology, visual test, and HPV DNA test. And now with the students, this question will come in their mind that why screening is possible for cervical cancer. So to fit a disease into screening, the condition should pose an important health problem, which cervical cancer is. The natural history of the disease should be well understood, which we all know about the HPV association and its natural history. There should be a recognizable early stage. Surprisingly, this cervical cancer has a very long precancerous stage even, and after the HPV infection happens. There should be an recognizable early stage, adequate facilities for the diagnosis and treatment of the abnormalities detected, suitable, acceptable test. The cost of the screening program should be balanced against the benefit it provides. So if you go through all these points, you will be able to understand that yes, cervical cancer screening is possible and elimination of cervical cancer is possible with proper methods and armamentarium in our hand. So I will restrict my talk today in screening methods. The screening methods, as I have discussed, are HPV testing, visual methods, pap smear cytology. For the pap smear cytology, we have conventional and liquid-based cytology. For the visual methods, we have visual inspection on acetic acid with 3 to 5% acetic acid, or VILI, or visual inspection with glucoside. For the HPV test, there is DNA testing, there is mRNA testing. DNA testing, WHO 2021 recommends the DNA testing can be done by self-sampling or the provider-collected sampling. The mRNA, the study so far has been done on mRNA testing is strictly restricted to provider-collected samples only. So there is no role of self-sampling. So now I will quickly go through the cytology. The cervical cytology is the most commonly used screening test for detecting cervical precancers and cancers. As I have shown in my previous slide, that Papanicolaou described the use of cervicovaginal smears in 1928 and was utilized as a screening test. Terminology has been revised time and again from Bethesda system in 1988 and revised in 2014. There is two methods, conventional and liquid-based. For the conventional, the directly smearing the material into a glass slide and immediately fixing the specimen with ethanol. And for the liquid-based cytology, placing the cytologic material in a liquid fixative and a filter preparation for making the slide. So how the reporting has been done? Reporting is the Bethesda system, which we follow strictly. There were multiple classifications, the CIN system, the dysplasia, the Papanicolaou system. But the mostly what we follow is a Bethesda system of classification, where the negative for intraepithelial lesion or malignancy, infection, as US, as H, LSIL, HSIL, and squamous cell carcinoma. So the terminology mild, moderate, severe dysplasia, carcinomas in situ is no more used. It has been replaced by HSIL and come into the umbrella of HSIL, where the CIN severe dysplasia and carcinoma in situ has been clubbed together, which were previously known as CIN3. So these are the types. What are the things we have to see for the cytology reporting when it is being done? The cytopathology should undergo the specimen type, adequacy of specimen, general categorization, interpretation of the result, and in the adjunctive testing is required, like the sample in liquid-based cytology which is being collected can be used for HPV DNA testing or other reproductive tract infection testing. And in the modern era of AI, the computer-assisted interpretation has also come into the play. The epithelial cell abnormalities or the glandular cell abnormalities, AGC-NOS, AGC favoring neoplasia, adenocarcinoma in situ, and if any endometrial cells seen in more than 40 years of age, that also has to be reported, and of course the carcinoma. So the women has to be like consent is important in the lithotomy position, introduction of the speculum, then take the spatula, and I will be demonstrating it in this video where the this is a Coughlin's jar which contains 95% of ethanol. This glass slide should not be air dried. This is an IR spatula where after consent, after evacuation, the pointed tip should be rotated 360 degree towards the ectocervix, and then smear it on the glass slide. Then don't air dry. This is a way of taking the cytology smear by conventional way. The rotation should be full 360 degree. Then you dip it. Don't allow it to air dry. This is an endocervical brush which needs to be introduced and rotate it 180 degree to sample the endocervical cells and then take it out. And then either you smudge the smear on another side or on the opposite side, and then again dip it in the Coplin's jar and send it for cytology examination. So now the question is, what is the difference between conventional and liquid-based cytology? So the liquid-based cytology for requirements is that the speculum, the brushes are different, like this endocervical brush. This looks like an endocervical brush. The preserved side, the BD short pad, the thin prep, these are the brushes which we usually use for the LBC sampling, and the fixative vials. But the difference between conventional smear and liquid-based cytology in interpretation of cells is similar. But the difference is the LBC slides are more clearer. So there is chance of less unsatisfactory samples. The randomized representative transfer of cells, even distribution of cells, are more clearer, minimizes obscuring materials, because in conventional smears, the slides are very busy and it may show the non-representative transfer of cells, and the clumping and overlapping. If this it has been air dried, the clumping and overlapping of cells is very much a problem for proper interpretation of conventional pap smear. But if we go by the result, there is no improvement in sensitivity over conventional cytology. So a good cytopathologist can interpret both through conventional smear versus liquid-based cytology. And of course, the cost is also a bit higher for the LBC samplers. So these are the slides which shows, the conventional versus LBC. So we as gynecologists also can fetch the idea from these slides that LBC slides are more readily interpretable than the conventional smears. So now I will quickly go through the co-testing where the combined cytology and HPV DNA testing can be used as a primary screening modality. But there is no no difference in the routine screening age interval. It is done every 5 yearly. But what are the advantages and why it is not very much, is recommended now? In fact, the co-testing is an unnecessary adding cost, and with a maximum of 2 to 3% of added sensitivity. The advantages is, yes, it has a high negative predictive value, very high level of reassurance, leads to earlier diagnosis, helps in finding more adenocarcinoma in situ than cytology alone, allows spacing of screening in every 5 years, which is not possible for the pap smear testing. The screening interval is every 3 years if the cytology-based test is used as a screening method. But the disadvantages is unnecessary high cost, unnecessary workup procedures, no corresponding decrease in cervical carcinoma incidence, and with a very 2 to 3% increased incidence with the sensitivity with added cost. What are the advantages of cytology? It is most commonly used. Developed countries like United Kingdom has a very well NHS-based cytology-based cancer screening method, which has shown that high specificity, same cervical sample can be used for HPV testing. And in developed countries, there is a significant reduction in cervical cancer. But what are the limitations, which is implementing it in LMICs like India, which needs infrastructure, delayed result, sensitivity, depending on the cytopathologist experience, is inconsistent. It can vary from 50 to 90%. Observer dependent, stringent quality control is required and requires trained pathologists with an interval of 3 years between 2 routine tests. So what are the alternative screening tests? Visual test, HPV DNA test, the molecular markers, and biophysical tests. So screening strategies, I would quickly go through the screening. The VIA test. The VIA is cheapest among all three screening methods available now. So what are the equipments? Examination table, stop clock, stopwatch, a sterile speculum, a good quality light source, a pair of gloves, cotton swabs, freshly prepared fluorescent acetic acid, sponge holding forceps, and a bucket containing 0.5% chlorine. So even if we are planning to screen and treat at the same time, we can use a thermal ablator device as well to treat then and there with the implementation of single visit approach as recommended by WHO. So how do we do this? Like consent again is important, lithotomy position, introduction of the speculum, and the proper exposure of the cervix is important, and see if there is any discharge, any vaginal mucosa appearance, and tighten the speculum. The cervix should be in the middle and should be properly exposed. Tighten the speculum, and see if the patient is comfortable and you are able to see the cervix, full ectocervix properly. And then next step, you see the using the LED light, you see the transformation zone. The middle red granular part is the columnar junction. The periphery is pinkish smooth epithelium is the squamous epithelium. In between these two are the squamo-columnar junction. And then these small dots like Nabatean follicles and the squamo-columnar junction, those draw a imaginary 360-degree circle, and this will be the any white lesion appearing within this zone should be suspicious. Now you start applying acetic acid. Remember, you bathe the cervix gently with acetic acid and don't rub or don't brush it, because endocervical canal has multiple blood vessels and these are thin epithelium. So they will start, otherwise they will start bleeding if you rub it off. Now see any whitish lesion appearing within touching the squamo-columnar junction should be seen properly and cautiously, as mentioned, as seen in this video, that there is a acetowhite lesion which is arising from the squamo-columnar junction and which is within the transformation zone. So the interpretation of this test is VIA positive. The interpretation of the VIA test is VIA positive, VIA negative, or VIA suspicious of cancer. So if it is positive, you either, if you have the equipments, if you have the trained physician or the person who is trained in performing the biopsy or the procedure like thermal ablation, you can proceed with it, or else you refer the patient to a proper center where she can be taken care of. So this is this recording is done with a colposcopy image, so that the VIA positive, you can see that the green filter has been switched on and the whitish lesion becomes more white and more visible. So this is the VIA. The interpretation is this is VIA positive. Now the biopsy. Then you apply Lugol's iodine, and now the biopsy, if required, should be taken from this dense acetowhite part which is touching the squamo-columnar junction. Suppose there is some lesion here, we can see. Suppose there is some lesion over here, but the worst affected lesion and closest to the squamo-columnar junction should be biopsied for CIN lesion. Now the interpretation is VIA positive, and when you are applying Lugol's iodine, it is VILI or Willi positive. What is villi? Villi is the squamous epithelium contains glycogen, whereas precancerous lesions and invasive cancer contain little or no glycogen. So precancerous lesions and invasive cancer do not take up iodine and appear as well-defined thick mustard or saffron yellow areas. So what is Lugol's iodine? It is potassium iodide, 10 gram added in distilled water in 100 ml, and iodine crystals with 5 gram added while shaking. So the interpretation of villi is test negative when there is no squamous epithelium turns mahogany brown. Villi is positive when there is well-defined bright yellow iodine non-uptake areas. It is difficult for the beginners to interpret villi findings, and more or less now the importance of villi has been restricted in delineation of the acetocyte lesion more for taking proper biopsy. So now acetic acid application is the first step, and doing a VIA is the first step. So there is a IARC, the cancer wing of WHO, International Agency of Research on Cancer, does have this atlas on VIA with acetic acid for screening, triage, and assessment. Is freely downloadable and available. And there is some atlas, another atlas on colposcopy as well in IR site, which is freely downloadable and can be helpful. So what are the advantages of visual test? It is done in basic setups. The cost of doing a VIA in public as a public health procedure is around 2 to 5 Indian rupees. So you can understand that how cheap it is and how easily it can be performed with less trained personnel as well. The cost is low, can be done in limited results. It is a real-time test. So the results are immediate with an acceptable sensitivity and specificity. As I mentioned in my previous slide, that the pap smear needs trained cytopathologist, and it has inter-observer variation, which is also applicable for visual test as well. But the cost of the visual test is cheaper and the results are immediate, so that the interpretation, even if the chances of over-treatment is more in visual test, but it can be taken care of by a single visit approach. There are studies which showed that even if there is implementation of visual test alone, there is 25% reduction in incidence and mortality of cervical cancer. So, but the limitations are, it's definitely is a low specificity, moderate sensitivity. It is observer dependent, and it is solely dependent on the visualization of squamocolumnar junction and associated transformation zone, which is not very visible in postmenopausal women. So that the utilization of VIA test is limited to the age group between 30 to 50 years, and it is not appropriate for postmenopausal women, where the transformation zone and the squamocolumnar junction recedes inside the endocervical canal. So for them, which is more applicable is the screening strategies is HPV DNA test. So what is the HPV DNA testing role at present scenario? It is a primary screening for cervical neoplasia. It can be used for as a reflex test for ascus cytology. It can be used as a test of cure, like a positive patient who has been treated and repeat the test after a year. She can clear it off, or she may have a persistent HPV, so that it will depend on taking another decision in further management of the patient. In screen and treat algorithm, HPV self-sampling results are comparable to provider collected in detection of cervical neoplasia. So this is a highly sensitive and specific test, and it is an objective test, lab-based test, which gives you the interpretation that if it is positive or negative. So here the cytobrush, which is used for the collection of HPV sample, it is done by various methods. This vial, which is already pre-filled with preservatives with HPV, and this endocervical brush, which you have to insert. The outer bristles should be just outside the canal when it is been collected by provider collected samples. Then remove the cap, and then you put it inside the preservative and just break the snap the stick and it will be ready for transport and further testing. So this is how simple it is. For the self-sampling method, it is the woman in her own privacy can perform it, and the high vaginal, so it is like taking high vaginal swab, which has shown that it gives a similar result with similar sensitivity and specificity in detection of cervical precancers. So what are the factors we have to look for when we are applying that which screening method should be used for which women? So age of the women, as I mentioned, that the in postmenopausal women, if you have all the three modalities, the HPV DNA testing is the best. What are the prior screening which has been done? Any past history of cervical precancers and treatment, and HPV vaccinated or not? Like if with the availability and the high sensitivity of HPV DNA testing, WHO also recommends the HPV DNA testing as the primary screening method. So this WHO guideline published in 2021 has divided it into general population and women living with HIV, where the screening is recommended from the age of 30 years. HPV DNA test as primary screening test with or without triage. Though the specificity is lesser of HPV DNA test than the well-established cytology-based test, but with a lack of trained cytologists, laboratory test, inter-observer variation with a wide variation of sensitivity, it has been seen that the studies have found that the implementation of HPV DNA testing is far more more feasible and practical in countries where the PAP-based or the cytology-based screening program is not established or is not in place. The triaging can be done by genotyping, as I mentioned in my previous slide, that 16, 18 are the main types, and apart from that 31, 33, 45, 51, 66, 68 are the types where the triaging, the partial genotyping can help. That if it is positive, then you have to go for colposcopy or further testing, or there is no restriction in which test to be done. The screening interval, you can perform partial genotyping, you can perform colposcopy as a triage, you can perform by VIA or a cytology. So all these screening methods are interchangeable and is applicable according to the time, place, person, and availability of the methods. The screening interval should be 5 to 10 years if HPV and 3 years if cytology test. So in Indian population, the Indian guideline says that recommendation should be, and our FOGSI GCPR guideline also recommends the screening age between 30 to 65 years. With 50 to 65 years who have never been screened should also be prioritized. The screening should be stopped after the age of 50 years. The screening stopped after 2 consecutive negative screening results consistent with the recommended regular screening intervals. So these are the WHO recommendation by HPV DNA or cytology and treated cases for general population and women living with HIV. So what is the importance? Why this HPV? A few slides on this. That what is the difference of HPV infection in women living with HIV? Though HPV infection and HIV infection associated with low CD4 cell count has been consistently and strongly associated with HPV infection and cervical precancers. The higher rates of HPV infection and CIN in adolescents with HIV, regardless of whether HIV was acquired vertically or horizontally. So genital warts are common in this group, and cervical cancer is a age-defining illness in HIV positive women. So higher prevalence of persistent HPV infection with multiple high-risk types, increased susceptibility leads to greater risk of cancer, precancer, increased risk of developing invasive disease up to 10 years earlier than in women not infected with HIV, and more frequent presentation with advanced disease with smaller chance of survival and more chances of recurrence for 5 years. So the cervical cancer screening is different in this population, particularly where the introduction of antiretroviral therapy reduces the risk of opportunistic infections and some less carcinogenic types, which has been shown that has some important role to play in etiology of cervical cancer. So the screening test starts from 25 years in women living with HIV. The screening interval is after 3 to 5 years when HPV DNA detection as a primary screening test, whereas in general population it is 5 to 10 years. And regular screening intervals should be restricted to 3 years when using VIA or cytology. So what are the national programs for cervical control? The National Cancer Control Program, National Program for Prevention and Control of Diabetes, Cardiovascular Disease and Stroke. NPCDCS is the latest program which has many versions implemented across various states, primary care, secondary and tertiary level care, with mostly used mostly the national guidelines say implementation of VIA in large scale population in relevant to our country at present. But definitely HPV DNA testing is the primary method of screening if available and affordable by the individual. But what is the in my last 25 minutes talk, what is the most important effort in elimination of cervical cancer? It is, we know everything about the disease, we know everything about the virus, about the available screening methods, pre-cancers, cancers, the pre-cancerous treatment. But the most important is linking screening with treatment. So doing a screening and the woman is screen positive and sending her home, or the patient is lost to the women, not patient, the woman is lost to follow up, is of no use. So it has to be linked with treatment or proper further testing and diagnosis and treatment. So appropriate counseling is important, regular follow-up is important, and routine screening is important. Remember, the screening which is being done for the cervical pre-cancer or cancer, they are normal general normal women. They does not have any symptoms. They are totally asymptomatic, and they definitely have it's by human nature only. It will be a tendency to not follow up regularly. But here comes the liability with us, the doctors, to insist on the importance of regular follow-up and routine screening. So with this effort, our Indian government is also is making a effort in developing affordable HPV test, which is now soon be available. The self-sampling for HPV DNA detection, the portable colposcopes, the proper manpower training, the national bodies like FOGSI, our ICOG, the other gynec oncology bodies, the preventive oncology societies. We have this regular seminars, webinars, awareness talks, orientation, importance of HPV vaccination, which I have not covered today in today's topic, and implementation and introduction of artificial intelligence to various mobile apps, or the detection of cervical pre-cancers or cancer by AI inbuilt portable colposcopes are important in reduction of the cervical pre-cancerous lesions. So in my conclusion, I would like to say that we know that HPV is the causative agent of cervical cancer. Screening tests can be opted according to the resource settings. Primary screening is recommended, but the most important is linkage between screening and treatment of positive cases are important. Thank you so much. I hope I did justice to my talk.
Thank you so much. Yes.
Thank you so much.
Yes,
for
sir.
an excellent journey through the cervical cancer screening program. And we could see the passion involved in the talk, because you are really involved in this cancer screening program and the elimination of cervical cancer from our country. I hope that the students have benefited tremendously, and not only your lecture, but also the hands-on demonstration on the models is extremely useful for the student. Thank you very much for joining us. Thank you so much.
Thank you, sir. Thank you.
Thank you so much, Dr. Deepanita. I think I am sure you have completely done justice to the topic, and I'm sure this will be lots of helpful for the students. So thank you once again. So Hafiz sir, we can start with the
before Hafiz, no, before
yes,
we
sir.
start with the quiz, Dr. Ashish, if we have any queries or any questions from the student, we can take. who is our host, if they can tell us if there are any questions in the chat, then please tell us, and then we will try to answer those queries, and then we'll proceed.
Yeah,
who is our host today?
That we will lose the screen once we go into the quiz, because that's a very involving type of program. So if you have any queries, kindly raise that or post that in the comment box, and then we'll take it up.
Is there any from the host side, if someone can tell us?
So chat box mein there are some.
No, they will, yes. Dr. Ashish, please see, and if you can try to answer.
Actually, I had to log out from my system of laptop, and now I not being able to follow it up to the mobile.
Okay.
Can you see the comments from the chat box?
Sir, I don't see, because I think the participants are on the other side of the system.
No, host has, sir, host has
Yeah,
to
yes, sir. Host has to
copy and paste it from there to us.
Yeah, you can do that.
Who is the host? Who is the host today? Is there anyone? Yes, who is there? Who is there? Who is there? Yogita, if you're there, Yogita.
Yes, sir.
Just see on the other side if there are any queries by the student, and try to post it on, or try to read from there. We will try to answer.
Sir, there is one question in the chat box.
Yeah, please read so that everyone hear it.
I think it is related to the fetal growth.
Yogita,
it has no
please
relation
read it.
with cervical cancer screening.
Any other? Yogita.
Yes, sir. I'll share in chat box.
Try to
Right now,
read
no
it.
more question.
Okay, then we can start with the quiz.
Yeah, good afternoon. Thank you.
So, Dr. Ashish, you are muted.
So, Dr. Archana, we welcome you for this month quiz.
Thank you so much.
As we can convey from the student side that your quiz program is very popular and the students are always looking for it. But I just request in between that try to see that the winners are getting their prizes. Whatever
Yes,
way you
that
try
was
to,
my query. Actually, I will just.
Yeah, no, you try to see to it that prizes are delivered to the students.
Yes,
otherwise, we will lose our popularity.
Yeah, yes, sir.
So I do acknowledge the efforts of Dr. Parag Biniwala sir for giving me this opportunity to conduct quiz every month with this PGICOG clinic. This Sunday, today we are having the topic heart disease in pregnancy, and myself, Dr. Archana, Chairperson Quiz Committee with Bhavna Tiwari and Dr. Himanshu. Dr. Bhavna is from Patna and Dr. Himanshu from Guwahati. Today we'll be the quiz master. So I'll be sharing the screen. Just give me a minute. Yeah. So, is my screen visible?
Yes.
You are, yeah, okay.
No, my Kahoot, is it visible? No.
Yeah, it's visible, madam.
It's visible?
Yeah, it is visible.
Okay. So I will start the quiz. The game pin is being loaded. All the participants, you are supposed to enter the game pin into your mobile where you have logged in through kahoot.it. And I'll be waiting for the participants. So just start entering this game pin into the kahoot.it. Yes, we have one participant. Quickly log in by just entering the game pin, or you can even scan the QR code also. We will wait for maybe 5 minutes. Please enter your nickname properly, because I can see one is entered as triple X. What does it mean? You enter the proper nickname so that we can identify you. At the end, if suppose you are the winner, we are able to identify your name. T, please rename yourself. So we have 34 participants till now. Please log in quickly. Already we are little behind the schedule. So I will just start when we reach 50. We are at 42 participants now. So I think I will start now. So this quiz today, we are starting the quiz, and I have not logged. So if participants require, they can enter. So this is the quiz on heart disease in pregnancy. We have 3 rounds, each round having 10 questions. So this is the first round, which will be conducted by me. And here is the first question for you. Cardiac output increases by heart disease in pregnancy by what percentage? So your choices are here. I'm getting the responses very fast. Yes, so correct answer was 40%, and most of you have got it right. Next question. We'll see the scoreboard after maybe 5 questions. The secondum type of ASD is associated with myxomatous mitral valve disease, endocardial cushion defect, sinus venosus defect, none of these. Answers are pouring in very quickly, and we already have almost all participants done. So the correct answer was myxomatous mitral valve disease. And I'm sorry, only 7 of you got it right. Next question. Preconception closure of ASD is recommended when the ratio of pulmonary to systemic blood flow is 1:1, more than 1:2, 1.2:1, more than 1.5:1, more than 2:1. So the correct answer is more than 1.5:1, and 20 of almost half of you have got it right. This is the next question. The most common congenital heart disease found in adulthood is, this is relatively easy question. The options are bicuspid aortic valve, VSD, ASD, PDA. Well, the correct answer is ASD, and nearly half of you got it right. The next question. Heart disease with maximum risk of maternal mortality. ASD, VSD, Eisenmenger syndrome, MVP, that is mitral valve prolapse. Oh, this is very quickly. We got to all the answers. Let us wait for the time to be over. Yes, I think almost all of you have got it right. All of you have got it right. 52 out of 52, it is Eisenmenger syndrome. So let's have a look at the scoreboard. Nikita is at the top, followed by Mrinal and Arpita. So the next question of this first round, pregnancy increases the risk of myocardial infarction by 2-fold, 3 to 4-fold, 4 to 6-fold, or their risk remains same. The correct answer, most of you have got it right. It is 3 to 4-fold. Next question. Which cardiac condition is not a contraindication to pregnancy? Pulmonary arterial hypertension of any cause, hypertrophic cardiomyopathy, severe mitral stenosis, native severe coarctation. Well, this was relatively easy. So I see the answers also to be answered by most of you. 43 got it right. It is hypertrophic cardiomyopathy, which is not a contraindication to pregnancy. So we'll see the scoreboard after some time. Cardiac failure in last month of the pregnancy or within dash months postpartum indicates peripartum cardiomyopathy. So is it 6 weeks, 12 weeks, 5 months, or 1 year? Okay, the correct answer is 5 months, and only 27 of you got it right. So again, Nikita is leading, followed by Mrinal, and Pragya is now third. Next, let us see the next question. Preconception aortic replacement, or MTP, is strongly considered for patients with ascending aortic diameter of more than. I think this was being discussed during the case discussion. So the correct answer is 4.5 centimeter. Almost half of you have got it right. And I think the next question for this round would be most common arrhythmia in pregnancy is SVT, that is supraventricular tachycardia, ventricular tachycardia, long QT syndrome, inverted T waves. Again, an easy one, I think. Okay, most of you have got it right. Supraventricular tachycardia is the most common arrhythmia of pregnancy. So the scoreboard, Nikita is at top, followed by Pragya, and followed by Nidhi. So that brings us to round 2, and I request Dr. Bhavana Tiwari to please conduct the quiz in round 2. Yes, Bhavana.
Thank you so much, ma'am. Thank you so much, ma'am. So with this exciting quiz continues, and we come to the second round. Can we have the first question, ma'am?
Yes, this is. I think she have lost connection or what, I don't know. So
this is the question. All of the following can be considered as significant murmurs except pansystolic murmur, continuous murmur, late systolic, or ejection systolic murmur louder than grade 3/6. So they're answering very fast. 33 of you have already answered. We have still time left. So the correct answer is continuous murmur, and 19 of you got it correct. So with this, we move to the next
only
question of
10
this
of
round.
them got it correct, only 10.
Yes, ma'am.
Okay, next. We'll skip the scoreboard for now. The question.
Nikita is still leading the scoreboard closely.
I think, Bhavna, your network is little bit disturbed.
All are true except.
So already they have answered, Bhavna. There was some.
Am I audible, ma'am? All
you
are
are audible, but this question.
All are true except in women with pacemaker. In women with pacemaker.
Bhavna, they have already answered this question. So the correct answer.
It's no correct, ma'am.
Yeah, your net is some problem. They've
Yes,
already answered the question, and only 3 of them have got it right. The answer is, in women with pacemaker, always use unipolar diathermy during cesarean section. That is a wrong statement. So, Bhavna, can I move to the next question?
Yes, ma'am. Yes, ma'am. Sure.
This is the scoreboard. Nikita is at the top from the beginning. So the next question.
Alarming sign in managing antenatal women with known cardiac disease. All are true except. So here are your options. Sudden increase in loudness of murmur, rise in NYHA classification, appearance of a new murmur, or rise in heart rate.
So the correct answer is rise in NYHA classification by 1 class, and I'm sorry that only 6
of them have got it correct, ma'am.
right.
Rise in NYHA class 1 by.
But still Nikita is leading the scoreboard. Next question.
Next question. Emergency contraception or morning after pill is contraindicated in women with heart disease. True or false? They're answering it fast. 8, 7. We have few 5 seconds left. Okay, and most of them have answered correctly. 33 out have correctly answered. The answer is false. It is not contraindicated in women with heart disease. So we can move to the next question.
I've never seen a persistent leader in the quiz in past. So Nikita is leading right from
Nikita
the
is
beginning.
continuously leading, ma'am, closely followed by Mrinal.
So this
we'll
is
have
the
the
next
next question. Severe cyanosis in pregnancy is defined as arterial saturation less than 80 to 85%, 70 to 75%, 60 to 65%, or less than 60%. It's great to see their enthusiasm, ma'am. They are answering so fast.
Yeah, and I'm sorry for the typing error in the first choice. So the
correct answer is 80 to 85%. So if the saturation is less than 80 to 85%, it's diagnosed as severe cyanosis in pregnancy, and 15 of you have correctly answered. We'll move to the next question.
So we'll
Nikita is still leading the board, followed by Mrinal. In cases of peripartum cardiomyopathy, hypertension is present in what percentage of cases? 20%, 40, 60, or 80%? So 3, 4 seconds left. 3, 2, 1. Time is up. And the correct answer is 20%. 21 of you got it correct. So 20% cases, hypertension is associated with peripartum cardiomyopathy. Next. Which heart lesion is not well tolerated during pregnancy? Mitral stenosis, aortic regurgitation, ASD, or pulmonary stenosis? Which one is not well tolerated during pregnancy? Few seconds left. Most of them have already answered. So the correct answer is
mitral stenosis. Yeah. So we will skip the scoreboard. Next question.
which medication is contraindicated in pregnancy due to fetal toxicity in heart patients? And your options are labetalol, digoxin, warfarin, or methyl-dopa. This is an easy one, perhaps. Fetal toxicity. So contraindicated in patients with heart disease. Yes, the answer is warfarin, and 36 of you have got it correct. So we'll move to the next question. The scoreboard, still Nikita is leading. What is the tocolytic of choice in patients with heart disease? The answer options are nifedipine, atosiban, max sulfate, or ritonavir. Tocolytic of choice in heart disease patient. The answer is atosiban, and 25 of you have already answered it correctly. So we'll move to the next question. So still the scoreboard, Nikita is leading with more than 11,000 points, and then Mrinal is closely following her, followed by Nidhi and Arpita. Coming to the next one, which cardiac lesion is most likely to cause pulmonary edema during labor? Aortic stenosis, mitral stenosis, ASD, or VSD? Pulmonary edema during labor. And the correct answer is mitral stenosis. Most of you got it correct.
Yeah, so that brings us to the end of round 2. I think we are done with 20 questions and we have the scoreboard.
I request Dr.
Nikita
Himanshu to take over. The scoreboard is being led by Nikita, closely followed by Mrinal and
So Himanshu,
Yes,
are
thank
you
you,
there?
ma'am.
Yeah.
Yes,
So
ma'am, I'm here.
we start with round 3. Himanshu, your turn now.
Yes, so this is the final round, and gear up, everyone. So, ma'am, can I have the question?
Yes, this is the
Cesarean delivery
question.
is indicated. So this question, cesarean delivery is indicated in all except aortic root more than 4 centimeter or aortic aneurysm, old MI, severe aortic stenosis, warfarin within 2 weeks of delivery. So you have another 5 seconds to answer. So the correct answer is old MI, and 24 of you have correctly answered it.
We'll skip the scoreboard. Next question.
Yes, ma'am. So the next question is, in a pregnant woman with mechanical prostatic heart valves, most appropriate anticoagulation in first trimester will be warfarin throughout pregnancy, LMWH with factor 10 monitoring, unfractionated heparin without monitoring, or aspirin alone. So we have already received around 40 answers. You have 5 seconds more. Okay, so most of you have answered it correctly. The answer is LMWH with factor 10 monitoring. Nikita is still leading. Next question, in peripartum cardiomyopathy, which is most predictive of persistent left ventricular dysfunction postpartum, it is BNP more than 100 picogram per ml, NYHA class 3 or 4 at diagnosis, ejection fraction is less than 30% at diagnosis, or onset before 36 weeks of gestation. We have already received 38 answers. Another 3 seconds. And the correct answer is ejection fraction less than 30% at diagnosis. 37 of you have correctly answered it. So Nikita is still.
Yeah. Next question.
Okay. So which condition is commonly associated with paradoxical embolism during pregnancy? Is it Eisenmenger syndrome, peripartum cardiomyopathy, ASD, or pattern foramen ovale? So we have received around 30 answers till now. You have another 8 seconds left. Another 2 seconds. The correct answer is pattern foramen ovale. 16 of you have answered it correctly. Mostly have written is Eisenmenger syndrome.
So the next question.
Next question, which is the preferred vasopressor in pregnant women with Eisenmenger syndrome and hypotension during delivery? Options available are norepinephrine, epinephrine, phenylephrine, or dopamine. Another 10 seconds. So the correct answer is phenylephrine. 12 of you have correctly answered it. Next question is, which is not an indication for endocarditis prophylaxis during delivery? The options are previous infective endocarditis, unpaired cyanotic congenital heart disease, prostatic heart valve, or mild mitral valve prolapse. Not an indication. So you have another 4 seconds. The correct answer is mild mitral valve prolapse. Most of you have correctly answered it. Nikita is still leading.
Yeah, but second position is now.
Yes, Nidhi is giving a very good competition.
Yeah. Next.
Which statement regarding pregnancy and Marfan syndrome is most accurate? Pregnancy is contraindicated in all Marfan patients. Aortic root more than 45 mm is considered high risk. Risk of aortic dissection is highest in the first trimester. Vaginal delivery is contraindicated in all these cases. So you have another 3 seconds left. Correct answer is aortic root more than 45 mm is considered high risk. 32 of you have correctly answered it. Next question, risk estimation of cardiovascular system maternal complications with a Carprex score of more than 1 is around 5%, 27%, 50%, or 75%. So you have already received 40 answers. You have another 5 seconds. And the correct answer is 75%. I thought it is an easy one, but 2 of you have correctly answered it. In a pregnant woman with Marfan syndrome, in which aortic root diameter is elective CS recommended? 35 mm, 40 mm, 45 mm, 50 mm. This will be an easy one.
Yeah, we have been discussing Marfan syndrome in 2 or 3 questions already.
Yes, ma'am. So you have another 7 seconds. Almost 37 have given the correct answer. It is 45 mm.
So I think we are coming to the last question now. Then we'll see the scoreboard directly.
Yes, ma'am. Which cardiac lesion carries the highest risk of maternal mortality during pregnancy? Is it ASD, mild mitral regurgitation, pulmonary arterial hypertension, or supraventricular tachycardia? So this is the last question of this round.
Yes, and of the quiz also.
Of the quiz too, yes, ma'am. So 44 of you have correctly answered it is pulmonary arterial hypertension.
So that brings us, thank you so much, all the participants. I'm really overwhelmed by your enthusiasm. Let's see the final result, the podium. So Nikita at the top, followed by Nidhi and Roshni. I think Mrinal was also doing very well, but that is how this interactive quiz goes on. It also depends upon the speed with which you answer. So congratulations, Nikita, Nidhi and Roshni. We would like you to post your phone number and email ID right now in the chat box, because later on we are not able to trace you somehow. So please do that. We can't ask you to switch on your video mode. I don't know, because we are logged in through separate screen. So please write in your chat box your phone number, your email ID, please. Yeah, Himanshu, you can switch on your video.
Oh, yes, ma'am. Yes.
Yeah, and Bhavna, where are you?
Congratulations to all the winners.
Yeah, are they writing their this thing? Because always it is difficult to follow them up. I request the support team to please help us in getting the email ID and phone number of all the participants. Because just Nikita, Nidhi, and Roshni doesn't make any sense. How do we trace them for sending their? But for last 2 quizzes also, I have been requesting in the group. I have not got the detail. I got the detail only of first quiz, I think, which was conducted in January. So are they writing their? Are they identifying themselves in the chat box by their phone number and email ID? Yeah, who is from the support team?
Ma'am, I am.
Yeah, please, please
Hello,
help me
can
in
you hear me?
getting their
Hello, can you hear
phone
me, ma'am?
number and email ID.
Okay, ma'am, I'll share.
No, but last time also you didn't share. So how do we trace them? We don't have their record, no, when they log in. Actually,
they always log in with their phone number and email ID, madam. So the support team will actually get their details, no?
yeah, but they have not provided me with the detail last for the last 2-3 quizzes. I posted it in the group also. I was just making an Excel sheet of all the winners with their